recommendations and funding recommendations before we adjourn today. So I was looking out the window, and it's interesting. I think we may have some symbolic scaffolding outside the window to help put us in the spirit of the public health system that we wish to build here in the state of Indiana, and the importance of that. And certainly, I think the Commission's work has made it really clear to us that public health services are delivered in many different ways across the state of Indiana. And we need to make sure that the future state encompasses all of those touch points so that services are available to every Hoosier, conveniently located for those individuals and communities. And while the local health departments are certainly the backbone to the efforts in public health, it's also clear that additional help coming at the state level is needed to support them to really lift the public health system in Indiana. So I personally am very heartened by the conversation last month. I thought, feels like last week, but last month it seems like, we really had a robust discussion. Like the conversation was great. And so I believe we're well on our way to ensuring access to services. Certainly all hazards preparedness, which is so critically important in today's world. It's always been important. It seems like it's even more important with each day that passes. And sustainable funding. And so with that, I'd like to turn to Senator Kinley for any opening remarks you'd like to make before we kick off.
Thank you, Dr. Monroe. Does this help?
Yeah,
it does. All right, we finally got the PA system as part of the program. This is great. Congresswoman Brooks and I gave a briefing to the Indiana Manufacturers Association, and of course we didn't do as good a job as Dr. Box does, but we did our best. And so basically Dr. Box and then Congresswoman Brooks and I have now visited with about 35 organizations who work with legislators, lobby the state house. And so we've tried to lay a groundwork for this effort that we have here, which is so important. And I appreciated last month's meeting. And so I've been thinking a lot about this governance structure and how we need to put this thing together. And it seems to me that an overarching goal needs to be that we have the state involved and we have the local health department involved as the primary deliverer. And of course, the regional service people are critically important in that. But I think we need to think further about how we engage local elected public officials to be a part of our communication process. And if you all remember when the fellow from the Homeland Security made his presentation, somebody said, well, what's your biggest problem? And he said, well, the biggest problem is everybody has their own ideas of what they're going to do and nobody communicates with the other guy. And so I've been doing some thinking since our last meeting, and have some suggestions and some ideas to add here. So I've been pestering Dr. Box and Shane about those. And so we're going to have a chance to discuss those, but I'm really heartened by all the work that we have done, the work that you all have done, and the attendance is remarkable. And I think I might have mentioned it last month, but I gave the governor's chief of staff a briefing before that meeting, and one of his assistants said, how many people do you have that actually attend the meetings? And I said, I think everybody comes every time. And there was another person on his staff who had been coming to the meetings. She said, that's right. She said, it's amazing. They're all there. So I think that just tells you how committed you all are and how important this is. And so we're coming down to the home stretch. And so I'm looking forward to seeing what we can come up with. And thank you again for all your help on the program.
Thank you. Dr. Box, opening remarks?
Sure. Thank you, Dr. Monroe. So I think the amazing thing about traveling around and doing a lot of the listening tours, there were some very interesting things, obviously, that came out. But most importantly, what we heard over and over again was some of the same themes that our experts in each of these areas have presented to us in each of our work streams. So for instance, the need for more and consistent funding, we heard loud and clear, and the ability for them to be able to use that to address public health at the local level. The ability for nurses in many of our schools, they are providing a lot of the routine healthcare even for our students across the state. And the importance, especially in our rural areas, of that. And we saw that throughout the pandemic, how a school that didn't have a nurse, it was very difficult to be able to address COVID with that school system in the way we could with other schools that had nurses. And then clearly it illuminated, and what we heard was the need for better coordinated emergency preparedness planning and that ability to respond, not just as a county, not just as a city, but as an entire district or region, and then that coordination with the state. And I think all of that is clearly intertwined, right? Because you can't have that nurse there to respond to public health and make sure visual screenings are getting done and hearing screenings are getting done if we don't have the funding to fund that nurse for those schools and have that directed toward that. And you don't have emergency preparedness that's just Department of Homeland Security or just the Department of Health. It is engagement of the local public health and the EMAs and the EMS and our hospital systems, and the clear need for that. So I think that the commission's done really an amazing job on the individual so that we have chosen to present each of these work streams, represent countless hours of meetings with our partners across the state so that they can truly present the reality of what this looks like in public health across the state of Indiana. And I'm just incredibly proud of the work they've done, excited as we work through these last 3 work streams today. And I just want to echo Luke and Judy's remarks in that we really, really appreciate your dedication, and not just your coming, but I can see your engagement. You've read the things that we've sent out. You really are wanting to contribute. So thank you for that.
Thank you. Thank you. And Congresswoman Brooks.
Thank you, Dr. Monroe. Very briefly, I love this chart, this Healthy Hot Topics, because right now, and I asked Dr. Box about this, you said something like 50% of WIC recipients are probably out looking for baby formula. Okay, so the baby formula shortage is truly a public health crisis. And while we often, and this commission was formed, in the midst of COVID, and COVID is still with us as it's surging once again, but in a different way, fewer hospitalizations, fewer deaths because of vaccinations and so forth. We're now hearing about a whole new disease called monkeypox. First case in Massachusetts, cases in Europe, something most of us know nothing about. Like we knew nothing about COVID, like we knew nothing about Ebola, we being most citizens, we being just non-medically trained people. And I think the work of this commission is so critically important. This is your opportunity to really share with everyone what your concerns are about recommendations, what you're excited about with respect to recommendations, because ultimately we are getting closer to the end of this commission, where we hope to produce a report that you all can be really proud of. And it may not have everything in it you want, and it may have a couple of things in it that you maybe don't particularly like, but we really hope to get this commission's report to a sweet spot where you all can be really strong advocates, not only with your constituent groups that you represent, which are many, but also, with our legislators and with your local, local communities, local county councilors, city councils and county commissioners and mayors, and very, very important that, this is your opportunity. So I'm going to stop because I want to hear from you all. Thanks.
Well, thank you very much. So speaking of attendance, I skipped right past whether we needed to take attendance. Shane, do you need to do a roll call? I saw the quorum given the attendance.
There is a quorum. I think we're good to go.
We're good to go? Okay. All right, very good. So next, I'd like to call for a motion to approve the minutes. Do I have a second? Excellent. You got that, Shane? The first, second? All in favor? Any opposed? Okay, we have approval of our minutes. And now we'll move to our next agenda item. And Shane, I will call upon you to walk us through the public comment.
Yeah, thank you, Madam Chair. The number of public comments has started to trickle down a little bit. So we only saw 17 come in over the last reporting period. Several of those were related to opposition to the expansion of public health authority, as we've seen similarly in other meetings. On the workforce front, a little bit of a change, focusing more on mental health professionals and investing in vocational rehabilitation and incorporating the DD and ID populations into the work that we're doing. Some comments related to that, as well as focusing on incentives and retention programs across the state. We did have several folks also comment specifically on social determinants of health focus, particularly related to childhood and adolescent health and infant mortality rate reduction programs. And then on the public health funding side of things, again, another individual who was in favor of increasing funding. And then we also had a respondent who was opposed to using additional taxpayer funding for the work that we're investigating here. Several other comments that were kind of a little bit on their own, so I won't cover those. They're in your packet. And then shifting gears to the listening tour, we did include the last 4 listening tour stops in your handouts. Those are posted online, as well as what we've given to you. Again, those are so unique that and such a wide variety that I won't try and cover them here. However, if you have questions, I'm happy to answer those, or we can, with HMA, dig into the themes more deeply. In general, I think it was pretty representative of what we've seen and heard through a number of the public comments as well. However, there were, as we went around the state, usually 1 or 2 unique things that we had not considered, such as relationship with adult protective services, or how to partner with local law enforcement differently, and those types of things. So it really did help inform the conversation that we've been having, and I think was really helpful for us to share information with members of the public that we don't always get the opportunity to do so, and particularly outside of the metropolitan area.
Very good. Any questions for Shane? Kim.
May I? Yes. Just a question on timeline, and I had not thought to ask this earlier. So is the ability to use the public input form between now and our June meeting essentially the final opportunity for people to comment on the recommendations as they've been presented? Or will there be a period of time after which sort of final recommendations are packaged and all put forth, and then there's another window? Does that, I realize it won't be a formal public input opportunity, but just timing is really my question.
So I think, Kim, we've talked about that as an executive committee. I hope nobody goes, oh, but we do feel we're going to need a meeting in July to wrap things up. We just think by the time we get this through, get something written and get it to the commission to look at for the June meeting, there may be some things we still are pounding out and looking at. So I think input, right up until that time, we'll continue to share with the commission. Once that report is written and you guys are looking at it in July, that will be the time when that, in my mind, would end, unless someone else has a different thought process.
That makes sense. Thank you.
Mhm.
Very good. So thank you. Thanks, Shane. So now we're going to move to the next part of our agenda, which is a recap actually of the April meeting and revisit recommendations. And I'm going to turn back to Dr. Box to provide the recap.
So there were kind of 3 outstanding areas that we as an executive team felt like we talked around, danced around, discussed a little bit, but maybe didn't settle anywhere. One of those was discussion or kind of determining what those qualifications to be a local health officer would be. And you'll have more information about that in your packet. Also discussion around local health departments serving at the district or county level rather than levels lower than that. So the municipal level. And the last one was composition of those local health boards. So if you guys look in your packet, you will see this one entitled draft language considerations. And then there's one entitled The Question as Posed by Dean Halverson. I'm going to start with that one first. If you will recall, there was a lot of discussion about whether this needed to be a doctor, so an MD or a DO, whether it could be an advanced practice nurse, a PA with additional training, like their master's in public health. And Dean Halverson, I think, felt very strongly it didn't have to be a clinical person. It really could be a public health educated doctorate or master's prepared individual. So Dean Halverson's language is here. And Dean, I think I'm going to give you some time to just kind of address what you had written.
Thanks. So I guess it is a little flawed in its translation, because the inference was never that a person who's not trained should be allowed to be a health officer in Indiana, but that essentially it would allow physicians or non-physicians with training in public health, and training is essentially specified to be either a graduate or certificate in public health from an accredited public health school or program, or nationally certified by the National Board of Public Health Examiners. Those were the aspects related to training. I think that the idea here is not to take away from the really important contribution that our physician health officers are making. In fact, we want to celebrate that, but it is essentially to acknowledge that public health as a discipline, as a specialty, is actually an acknowledged body of work, of knowledge, and that individuals who have training in public health should be the ones, in fact, administering the health department. And of course, there needs to be a physician who has responsibility for the clinical oversight, and that is not in question. It's just the issue of the actual day-to-day running of the health department and speaking on behalf of the health department as the director, if you will. So this was the attempt, and I'm sorry it did make it a little confusing by making it appear as though training was optional. The last thing we want to do is to not require a physician and not require any training, because then we have a situation much worse than we are today. So it is essentially to recognize both the importance of the physician as the providing oversight, but at the same time to recognize the trained individuals in public health should be, in fact, responsible for running our health departments. And that is, by the way, consistent with the general practice of local public health in this country. Very rare, actually, to find that a physician's required to be the administrator of the health department.
Thank you, Dean Halverson. And then I will just kind of briefly address the language that Shane and I kind of put together. And I think that D addresses kind of that concept that this doesn't have to be a clinical healthcare professional that would serve in this role, that the Department of Health, the Indiana Department of Health could, through their board, look at qualifications of individuals and approve, provided there's that medical support, individuals to fill this position for a particular county. We also talked a lot about the fact that the training of a regional, or more importantly, a district health officer could be, if that's a full-time, and we believe that person would be a full-time person to assist local health departments that may not have, a local health officer that is trained in public health. So that support at that level and the amount of training they would have to have. Our goal in this language was really to make sure that our local county commissioners and county council had the broadest opportunity to state what was best for their counties or their communities. We already have health officers that are being shared, some because people have lost their health officers and they're struggling to find someone, which is a difficult issue. And so, you know, the ability to have a local health officer that covers more than one county or a particular county to have an advanced practice nurse or PA that has formal training in public health, we thought would be a good option. So really, this was just written with the idea that this gives more opportunity or options for our county commissioners who are working with the local boards of health to find these individuals and hire them.
So questions, clarifications, reactions? Brent?
If I could ask, so the draft language considerations are meant to, in some ways, resolve the questions, the document as posed by Dr. Halverson, right?
Right. It was trying to incorporate what Dean Halverson says is really the norm for many local public health across the United States, but it's not what the state of Indiana is used to. And I think you heard from Dr. Kane, who said clearly that there is also an issue of that trust that comes with having a physician leading, especially during a pandemic time. I mean, I know I got lots of emails and comments, you know, what in the, and you can pick your 4-letter explicative is a, you know, an OBGYN running our state in the middle of a pandemic, which, you know, I wasn't running the state, but realistically, that was the feeling, is that even 35 years of obstetrics and gynecology experience wasn't enough. And I respect and understand that. So I think that Dr. Kane's point when she was here before was that need to have an MD or DO that is, you know, has that level of respect automatically when they go to the mayors and the county councils and the commissioners, et cetera.
Well, I would say, even without the formal background, did a pretty nice job. So,
Thank you, but I didn't say that for that reason.
I think that, so my concern is less about, I think, the way in which we're providing some flexibility for an APRN or others. I think that's good. My thought in this area is that we've heard this in some of the field hearings I attended. I've heard it from my members, the challenge of getting people to serve in these positions. And I think some of the other things that we're doing, the kind of fundamental changes and the boards themselves will hopefully help bring people back into the pool. My concern is I don't want to narrow the pool too much. And so, when I looked at the question as posed and the second bullet about requiring the national training or certification, that's kind of where I appreciate the value of it, but I don't want to I hesitate to put a requirement on someone. They're going to come into that position, probably have to be really asked, maybe even cajoled into taking that position, and then to put too much of an additional burden, because many of these individuals, right, are wearing many hats already in the community. So, but it looks like in the language that it wouldn't necessarily have to be a graduate degree, that the department could sort of develop a curriculum essentially.
I think in conjunction with our public health schools, right? So that there's some kind of on-the-job quick training that can be completed over a number of weeks and kind of an orientation to public health.
Yeah, if that's, I like that as a solution to the more formal part. I think I respect Dr. Halverson tremendously and what the school does. And I think there's an aspirational element that we can talk about as far as where we get to, where as we have a more structured public health program, and we could hope that all of our public health officers would have that level of experience. But I think if we jump to it too quickly, especially at this critical time. So if this is kind of the way to sort of help address that, and the department working with Dr. Halverson and others can kind of form what that curriculum would look like in a way that doesn't narrow the pool, then I like that. I just wanted to make clear, we're not really choosing between sort of the one approach or the other. This is a way to kind of incorporate that idea.
That was our attempt at doing that, yes.
I think it does it from my perspective.
comment, question. Brian, I agree. I appreciate your comments. I guess when I read this, I kind of thought of it as perhaps, and it is a perhaps, this might be a little bit, and most everybody around the table probably isn't even aware of it, but the Management Institute that State Hospital Association runs for, I'll call them non-managers, that Dr. Tom DeCoster put together years ago, which ends up with a certificate. It's certainly not a degree or anything like that, but I kind of thought of it as something like that, that might be what this would entail. Several months, but maybe 3 hours every 2 weeks or something, so it's not too burdensome on the individual to go through this. And when you're done, you have this quote certificate. So I think that would be good. I don't know if Dr. Welsh has any comments along that line, since you may be one of those that's grandfathered in, I don't know. But you're a busy surgeon, 3 different hospitals, and a health department that covers 2 counties. So I don't know how that would fit in your schedule.
I would just introduce the concept as well, that for years we had nothing with regard to coroners training. And because of certain circumstances, the state now requires that every elected coroner go through the process and be certified by the state. So I see this as the same type of thing that we can do for our health directors.
Like the Corners Training Board. stuff.
Absolutely.
Okay, I see that. That's a great
That makes a lot
example.
of sense. Yeah. David?
Thank you. So I can probably hit several of the things that have already been suggested. I think if someone was asked, appointed, cajoled, whatever term, to take on a health department, they certainly would want to have some information at their fingertips as they take on this new endeavor. So I think having maybe from a medical standpoint, Dr. Fox would understand, that we have a core set of information that they would want to have available, and then have ongoing opportunities to upgrade their knowledge in the public health sector. And I think that could be easily done with the help of our good Dr. Halverson's organization and the State Department of Health. And if those sessions could be archived so that you look at it, and then, so now it's 2 years later and you've got a tough TB situation. Oh, wait, there was an archive thing on dealing locally with TB, and so they can go back and reference that, I think would be a good thing. I do like the suggestion that it would go, if people use alternatives at the local health department, that would go through the IDOH executive board. My suggestion would be that I think the APRN would go easier than the PA in that position. Certainly asking them to have more training in public health would be helpful. But I think it would need to be that should be tied to when, if and when they attain independent authority. And that'd be tied to whether it's a district or a state level medical oversight. It can get a little touchy when at one of my counties, I have an administrator, another one I do not. But even if I get up and say the exact same stuff the administrator does about something we're planning in the department, I tend to carry more weight than my administrator, even though she's really sharp.
Yeah.
And that's just the way it is. Now, the other side of this coin of asking for more training and asking for the oversight, it gets back to the funding that we've talked about before. So it was mentioned to cover several counties. Well, the one county, neither reimburses very much, but the one county is less than a third of the second county. I can tell you, there's other counties with the low reimbursement that you're not going to get people with the added training at the reimbursement that's currently being used. And we're already running into that when we talked about workforce, forget the health officer, the nurses, the environmentals. You're not going to, it's good to have that extra training, but if people aren't going to be paid for that extra training, they're not going to stay local. They may get that extra training and say, oh, I can move to a larger county and make use of that training and actually be paid appropriately. So I think if there would be, if alternatives, I would tie it to when they're allowed full independent practice, and really like tying in the setup needs to be tied in with okay by the executive board. That way you don't have folks kind of saying, well, we'll get Joe or Susie, and then we can tell Joe or Susie what to do because they're friends with so-and-so, and we all know that goes on. And we want to make sure that we help get the best public health resources to everybody in the state.
Thanks, Senator Kinley, and then Mindy.
Yeah, Dr. Box, I had
Thank you.
just a brief question on the draft language considerations under 1D there. It says has at least an MPH or equivalent and 10 years of experience. If you're trying to make it more flexible, is 10 the right number, or?
Actually, I had some discussions earlier and specifically with Dean Halverson, and 10 years is a lot. So we said several years so that way we could it could be 3 years, it could be 5 years, but it really would depend on, when we look at that individual candidate at the Department of Health board, executive board level, what was their level of experience and training?
Well, I'll leave that
So
to
we
you
would
all to
switch
kind
that
of
up. I think
pick
that's
a
good
number,
point.
but if you're trying to be more flexible about some things, you might want to say 5 or something like that.
Mindy?
Just a couple comments. I agree with like an à la carte mixture of all the things that have been said. And my opinion has changed over the last few years too, based on what has occurred and some of the now expected things. I have 32 years of experience, but I don't know that even if I sat through the CPH, which I'm planning to do, that I'd be capable of doing some of the things that were needed over these last few years. So I'm on the fence on some things. I do like the draft considerations here with one change, which I'll mention last, but things like what Dr. Welsh says is true, unfortunately. I mean, I do say those same things, but then I need somebody to come and back me up once in a while to become a bit political and a bit in your medical opinion. Our health officer is Dr. Sutter. In your medical opinion, Dr. Sutter, is this really needed? And there is some credibility, like Dr. Kane spoke to, that is needed sometimes. So whether that's a hybrid of they're an advisor or they're the health officer, I think our preference, at least in our area, is that is the health officer, the executive person. That said, a lot of the work is done by the administrators. That wouldn't change, I wouldn't think. But there is some need, I think, for that extensive medical training. I like the flexibility though, because cookie cutter isn't going to work here anymore. So having the ability that in situations, a county that right now us are looking for a new health officer, we're large, we do have some money. I can't find those people either yet. And we need them in a month. I tried to convince him, he won't take a third county. I honestly asked, he said no. It is hard. So I think as we go forward, if we can solve the root cause issue, the money part, so that takes all the stuff where we can entice, well, maybe we can, but we still probably need an à la carte option for different counties that might have a different need. For instance, we have many clinics. We prescribe a lot. We do a lot. We have a lot of disease all day, every day. And that is the backbone of public health in Indiana because of the communicable disease rule. Those don't go to hospitals. We need a physician. Friday night was a good example. Can't go into it, but nonetheless, I needed a doctor to give this particular prescription and decision. That it could be done consultation. I get that. So I kind of am leaning towards the draft considerations here with a tweak to C, possibly being that 6 months might be too short for a doctor. Cause I want to sit for that CPH and I read it and I'm like, I did the test. I couldn't even answer some of that stuff. I'd need significant months to train and a doctor wouldn't necessarily be full-time and have time. So maybe a year, just as a suggestion. And that's it.
Thank you. So then we have Kim and Congresswoman Brooks.
Yes, just to add a few à la carte comments as well. We've talked to about 30 Public Health Association partners through a couple of meetings, several of them with local health department experience and a few who are advanced practice nurses. And I think that the key thing, and I'll echo Dr. Halverson's words, are that public health in the local health department setting, from their perspective, that acknowledged, established body of science knowledge around public health is most critical. The clinical piece is needed, but what I heard in multiple ways was that that's where we have more flexibility in how we structure it, and that there's other models to look to. EMS was one of them that was referenced, the idea of the standing orders that have been used in so many cases. And so their perspective and sort of the collective was to stay focused on that public health experience as being so important as an option, meaning like, let's please include that and figure out how to make either a new model or replicate a model on the clinical side that still allows us to get what we need from an authority and established medical expertise standpoint.
Thank you. Thank you. Susan.
My only suggestion would be, as we've done in other areas where the state's trying to really succeed, like graduation rates from college, we have set benchmarks and have set goals for, I just read some article, by 2030, Indiana hopes to have X, I don't remember what the number was, percentage of people with some college degree or certificate. Maybe we could set an aspirational goal and phase in, set a time that we would like our public health departments across the state to meet, the goal of, whatever level of training or certification or education that you want, but that we work toward and know that, all the departments need to work toward that.
Right.
In addition to, I'm not saying we shouldn't put some, suggestions and or requirements in, but that we, realize that it may take a little bit of time, and that by X period of time, we will have, 80, 90% compliance.
Dr. Welch.
Thanks. I think all sorts of good suggestions. Some of you may have had a chance to see some additional information I sent out this week. In 3 weeks, the AMA meets, and the Council on Science and Public Health will have their second report having to do with public health infrastructure improvement. This one has to do with rural. Don't have to read through the whole thing, but just if you go to the discussion and the executive summary, it covers a lot of the things that we have covered. That's a coincidence, isn't it? But I think it may give the framework of when we're talking about what's going to work for Dr. Kane and for Mindy in the larger versus in the smaller counties is part of the challenge that we have to deal with. And I would just suggest taking a look at that. And if anybody has suggestions for me to take to the AMA on how that could be better, I'd appreciate that. I don't want to take up time now, but just that covers some of the nuances that we've been discussing. And I appreciate being able to bring that information to this committee. And quite frankly, I've been sharing stuff from our committee with that other council. So
It's a good report.
It's been a very good symbiotic work.
Yeah.
Thank you.
Thanks for
Yeah,
sharing it.
thanks very much for sharing that. I'm, a few of my own thoughts as I'm hearing the discussion, and I shared this in our executive session before, it was if you put this into more of a clinical model. Now, I'm an old residency program director, so I'm coming at it from having been a teacher and a practitioner. If we're marrying up this more flexible model at the local level to choose, to have non-physicians being at that local health officer, and you're marrying that with your district health officer, what you've created now is a preceptor model in some ways, or you've created that. So in the residency model, that would be like the preceptor with the resident in training, and you can always call them, right? Or you've got that mentor or what have you. So that I think has incredible value. And if that's a physician at that level, then that also brings in the doctor when you need them if you have a non-physician. So you solve a lot of issues there. The academic side, having the training, the your best practitioners are the ones that have married experience to academic, right? You've got to have the two come together. It's not one or the other. And so that's what I'm hearing, that you're giving a roadmap to reaching this more optimal level across the state, but it'll take a little while, right? So anyway, I find it exciting. And then I think, Mindy, to your point, we are in such a fast moving, changing world. We've, Congresswoman Brooks brought up the formula, the hepatitis in infants, the monkeypox, there are so many new things. It's what we don't know. It's like disease X, the one that's going to come back. It's going to be like COVID. It's going to be the one we don't know. That if we don't have everybody continuing to train, we're not going to be able to meet the needs of tomorrow. I mean, it's just a complex world. That's all there is to it. So are we at a point for a vote? Or how do you want to do this?
How do you guys feel about that?
I think we've heard what people said. Give us a chance to put it together for you.
Yeah.
Again.
Kind of rewrite
Give us
it?
a chance to redo a little rewrite and bring it to you again. Just
Okay,
That's the way I would do it.
sure, we can do that.
Yeah. So any other comments? Yeah.
Yeah, and maybe this has already been touched on a little bit, but C on the draft language, I would like it to see it say any LHO. It says position.
It
right
says
now.
what?
Right now, it says any newly appointed position serving as an LHO.
Oh, yeah, that would,
Should the language be adopted to prove an APRN or PA or even a non-provider?
Oh,
I think it should be anybody stepping in the LHO position. should
Right.
obtain
well, to me, a
that.
local health officer would be an APRN, an MD.
Well, this one just states that they
It
have to
just says
complete the
position.
Public Health Foundation.
Oh, it does say that. Okay,
So
Right.
I
gotcha.
would say anybody going into that position.
yeah,
should
whoever
complete
becomes the
that.
local health officer, regardless.
Sorry, I see it.
Yeah,
Thank you, Kara.
regardless. Right now, it just says, the way it's written just says position.
Good point. Thank you, Kara. Okay, we'll work on that. Let's go to the next talking point that we were going to consider, which is the focus of keeping the level of service at the county level or above for a public health department. As you know, we have 3 municipal health departments. I do want to share, I do have pretty strong feelings on this. And I did look up the Indiana Commission on Local Government Reform in December of 2007. One of their recommendations was to transfer the responsibilities of municipal health departments to the county health department level. So I think I throw out there a discussion. I know, Mayor Courtney, you've had some thoughts on this. The discussion about whether we stand firm and go that everybody's going to be the county level or above, or we say we grandfather in the 3 that are existing. Senator Kinley has been great to suggest that the counties would still have the choice, but the money would be allocated to the county commissioners and county council to decide how that money is distributed in the local county. So I throw that out there for people's comments. Boy, can I quiet a room?
Yeah, thanks for that. Kim.
Yeah, we had a
And then
good
Mayor.
amount of conversation about that in the couple of meetings as well. I think the primary takeaway was that given sort of current realities, that having flexibility and options is potentially a good thing. And that if we're actually limiting options through this mechanism, given that we can't predict necessarily, right? Just that it feels that it's cutting off potential options that we might wish we had later.
So you would go more with the leave it as it is in statute, that any.
We do not
second-class
have a formal recommendation at this point as IPHA
Okay.
is what I'll say. That the feedback was, and I think this came from a number of folks, they understand the concerns with it and they certainly understand the funding realities. Going back to sort of the best way to deliver services across the state and ensure, I'm blanking on the language we've been using, but right, ensuring everyone has access to the same
Mhm.
or to a certain level of
Equitable.
services.
Mhm.
Maybe having a municipal option should still be on the table. So.
Mayor Courtney, did you?
I would agree that we should leave the flexibility to allow a municipal, a local health department, and for a couple of reasons. One is the statutes that govern the health departments have been around for 30 years or so, and we only have a handful who have actually, taken upon themselves to form their own local health departments. So I think it's been stated there's 3 in the entire state, even though all 92 counties or hundreds of cities across the state of Indiana could have done it, relatively few take advantage of it. And maybe it is maybe it would maybe dilute some of the other good things we're trying to accomplish by changing how those services are delivered. I also want to point out that I was looking at a document. It was the county health rankings. And I just found it very interesting that this document was prepared for 2021, which ranked all 92 counties in Indiana for their county health rankings. And Hamilton County was ranked number 1 in health outcomes and health factors. So is it coincidental that there is a municipal health department in that county
Which
that is
just formed.
helping it?
They've always been number 1, even before there was a separate municipal.
But that also may indicate that they're not diluting the services by any means of what's being delivered there. I just find it interesting that the ability to form your own local health department's been there for so long, but very, very few find it practical because it's really, really hard. And then those that do probably have, I would think, sincere reasons on why they do it, because they want to deliver services and they're closer to their constituents. In cities and in counties and in towns, we all have our various levels of government, and we're close and we understand the need because we're closest to it. I would just be hesitant to create restrictions that are rarely used, but does appear to be delivering an outcome that is not detrimental to the overall mission of public health.
Okay, Senator Kinley's next.
Yeah.
Yes,
Then Mindy.
thank you.
Thank you. Bob, you and I have had a chance to have some discussions about this. And with 64 of our counties having a population of less than 50,000 and a little over 30 of those having less than 25,000, it's a real practical problem that we don't have enough mass there to effectively deliver services under the system that we have today. And so I tried to think of different ways to skin the cat to kind of pay attention to the things that you were saying, but still stick with the county level. And some of the things that this may have a bearing on your thoughts about it, but some of the things that I thought about were that as we restructure the composition of the local health boards, which is the next item on the agenda, one of my thoughts was, well, we have a problem with communication here, so let's figure out a way to get a member of the county council or the county commissioners to serve on the health board. Let's also find a way to get a mayor to serve on the board. And for example, maybe however many cities you have in your county, the mayors could jointly nominate one of them to serve. And then that would give you the opportunity to do that. And then I kind of felt like it was my idea that the funding should stop from the state at the county level. If the county and the local health department decides then that they want to have a substation in Fishers or Gary, that they could do that with the money. But I don't think we want to keep creating more health departments because we just don't have that critical mass in so many of our 92 counties. And so I was trying to figure out ways to help. One of the things you mentioned to me was, if you had a disagreement with the county officials or the local health department at the county level, you had no avenue or a recourse about how to get a solution to your problem. And I'm trying to come up with solutions and then take away your right to establish a city health department. So I think this is conversation is a little bigger than just the one thing about, are you giving access and things like that? So those are just thoughts.
And I agree with you, Senator, that the money should flow to the county. So anybody that lives in a city is also paying county taxes. If you have representation on that county health board, if the municipality or the largest city in that county had representation on the county health board, then they would have a voice and they could consciously decide through the county whether or not they needed to extend services into the city.
Right.
I think that recommendation you made is fair.
Mark, yeah, going down the line here.
I have a quick thought, and I hate to sound ignorant, but in the instance of a county and a municipality having separate health department structures, could that be considered by taxpayers duplication of service efforts within jurisdictions? And we typically do not prefer to have duplication of effort on government services. Again, I am a workforce person. I'm not a public health infrastructure delivery person, but I'm sitting and listening, and I'm wondering, we typically wouldn't accept duplication. So if it's all taxpayer dollars, and I completely 100% agree with local decisions and large municipalities being definitively part of the discussion and decision making. But my concern would be that we would be having duplication of efforts within the same jurisdictions, possibly offering varying services depending on whether you're in the city or not. And then our taxpayer dollars are going to ensure vaccines are located in the city as well as for the full county. So I'm trying to think of this as like, how do we begin to consider what this means when we start paying for it?
Cindy, you have the answer?
I don't. I do agree, though. And I want to qualify my answer that this is my opinion as Mindy and Allen County, not as representing all of the health departments, because I don't want to come across as making comments about the current municipal ones, because they have good workers doing what they're doing. And I don't know all of their reasoning for forming. So I speak nothing about them. But conceptually, Allen County and Fort Wayne had health departments. There was a Fort Wayne and there was an Allen County. They have obviously merged, but the reason for merging was the extreme dilution and inconsistency between service delivery. For example, there still are. There was a food ordinance in both of them. There was a septic ordinance in both of them. There were B ordinances over here, but not over here. There's smoking here, and we have 7 of them now. It was very difficult to have a citizen know what they had to comply with, or a McDonald's here, but a McDonald's here doing different things. It diluted, and it's hard enough with 94 health departments or 92 counties. So for many reasons, I think the majority would support the county for a number of reasons: funding stream, less potential of duplication, consistency, no waffling, that sort of thing. But I don't, again, want to say anything counter to what's currently functioning. I would be of the opinion of no more of them. And then, I'd leave it to the others to decide. It's too close to home for me to help with that decision on the current ones. But I am not a proponent of more of them. I've seen it happen.
Carl?
So sorry to my colleagues that are listening. Thank you.
I am somebody who believes pretty strongly in home rule and think that home rule is good. But on the other hand, I've never for the life of me understood municipal health departments versus the county one. My only experience is 10 years on the San Diego County Health Board, which of course is countywide. But I think as a practical matter, to get from where we are to where we need to go, I debate in my mind, what are we going to mandate versus what's the standardization? And I assume we want some level of standardization overall for the whole system. So from a standardization standpoint, one would think county level makes sense. But from the historical standpoint and from a home rule point of view, it might be useful to at least grandfather in the existing ones, but try to if you call for consolidation in the long run, because I think in the end, we need to have standard set of requirements, standard set of funding. We need some standardization overall. And continued fragmentation doesn't help that goal.
I mean, Mark, yeah, sorry.
I have a number of thoughts, and I don't want to get ahead if we're going to still talk about the appointments here in a few moments. I would say that our city, when it comes to being the chief one in the county, is where a lot of our service is going, even though we have a county department. So a lot of that service is folks from the city of Marion that are coming into the county health department. So again, I think it needs to stay mostly at the county level. The other thing that the mayor and the senator have both kind of addressed is Grant County just recently in our census, we went down under 70,000. And so state law now says that the commissioners appoint everybody on the health board currently. If we start looking at this, I would just add that more so, I know we want the county council to buy into what we're doing, but at the same time, I have a mayor of approximately 25 to 28,000 people that just has been removed from any of the dialogue because of current state law. It would be more important, I think, to have that larger community invested in the health board than the county council, since the commissioners are already appointing as well.
So does Senator Kinley's recommendation with the mayors, does that solve that?
It could.
Yeah.
It very well could.
Where there's representation?
I just had a question, maybe folks here can clarify. So we've got three that are separate from the county health department. Does anybody know the history as to why they set up separately? Was there problems? Was there concerns? And if there were concerns that weren't being heard, maybe it gets back to
You want the
Senator
real
Kinley's.
answer? Or you want the public relations answer?
One has dropped as well, right?
Yeah, Hammond
Right,
is no longer a health department. There were 4 up in Lake County.
There's a lot of politics behind that, Dr. Wells.
Okay, gotcha. Okay. So,
I'm from Hamilton County. I've got to watch myself here.
yes, sir. Yes, sir. So I think a lot of good comments. I think some of it may get fixed if we get more district-wide help. It also may get helped if there's more voice at the county level from the cities. So it might take care of itself from that standpoint. Thank you, Doctor. Thank you, Senator.
Any comments after you've heard all of this?
So again, I'm not sure exactly how I would be rewriting this. I think I need some direction from the commission on that. And so I don't know if someone wants to put forward a proposal and we could vote on that. Or Kim, go ahead.
Well, it is a clarifying question, and Senator Kinley, we do not need to go down this path if it opens up too big a can of worms, but my understanding, which may or may not be accurate, is that the tax code was not the tax code did not, does not fully address some of the issues that were raised by the creation of at least the last municipal in the Fishers in Hamilton County, right? It left kind of a gap about how to handle it and how taxes were spent. So my recommendation around language is just, I think we have to look at the tax code and to Hannah's point, the duplication. So conceptually, obviously there's decisions, but I think the tax code piece of that in my mind will matter.
You just threw a wrench into it that I don't really think I don't understand it well enough, so.
And if I could, I was trying to also recall what the avenues were that allowed Fishers to do that. And I represented Fishers at the time, I'm also a resident of Hamilton County. And I think to your point, and I don't know that we know enough about all of that. And I think certainly at a minimum grandfathering the existing, we don't want to, I think, be the source of lawsuits and other, it's Fishers and who else is Gary, East Chicago, and at East Chicago, Gary, and
Fishers.
Fishers. I mean, I think they have infrastructures in place and have been in existence, the others, for some time. I think that could be problematic. And I certainly wouldn't want our progress to be impeded by local officials, particularly the mayors of those communities. Having worked in a mayor's office in Indianapolis, and Indianapolis is lucky because it's a city-county government, okay? But when you have other large communities like Hamilton County with very large cities, all who compete frequently, I know, I represented all of them. They compete frequently for resources. Mayor Fadness found an opportunity to, and maybe a loophole or an opportunity through tax provision to create and to get what he thought, is my understanding, were services faster and testing and vaccines and things faster for his community than he thought he was going to get through the entire county system. So I think we need to be careful about it, particularly the existing. And
Yeah, so I'm hearing grandfathering in, certainly the ones that currently exist, and I'm seeing a lot of head nodding, and I think that was the intent, right? Dr. Box, you always thought should be that. Then the question is the new language, do we let things lie? Because, as Mayor Courtney said, that we haven't had an abundance of these. So do you go forward, or do we change language and then the I am intrigued by the representation.
Do you think that
Well,
could
I
change
think-
though with the increased funding that's going to come per capita? Do you think we might see more
Right.
second-class cities that stand up and say, I'd like?
I think we will unless we clarify what our recommendation is. And I think that in the conversations that I had with Bob, Mayor Bob, I thought he brought a legitimate concern to the table that he could be shut out in this process and wasn't participating. I think that the restructuring of the membership on the local health department so that you include a county elected official and a city elected official tends to not only help resolve this problem and give you access and input, but I think it also helps in this larger idea that in order for this whole exercise to succeed, the state people, the county people in the political offices, and the health department, all three have to be working together and cooperating. And that's what's going to make it work in the end. And so if we can put a structure there that encourages that, then I think we're moving forward. And I think that the idea of the city thing is just a distraction that can be overcome. And at a minimum, I feel like with this money and the things it's going to go toward, which need to be unified in their offering throughout the county, in every county that gets on the program, I think that I think that the money needs, even if you were to allow cities to have the current legal options they have, I think the money ought to go to the county and they ought to decide.
Senator, I
how
think your
it's
point's a good one,
distributed.
which is the natural path that a city is going to follow is where the money is, for one, and if they have a voice in the process.
Right.
And so without needing to restrict their capability, you create a natural incentive for them to follow the path in which you're wanting them to,
Some
I
funding
think.
to the county.
Yeah.
And I'm struck by the importance of the argument because I know when I first started talking to Dr. Box about this, she talked about the unevenness of services throughout this state. I mean, that's really a kind of an embarrassing problem. And I think that if you don't face up a little bit to this city issue and put the money at the county level, you're perpetuating one of the very reasons, one of the very things that you are fearful that is a problem. So
I think you're spot on with that. There's something kind of intrinsic about public health that it is delivered at a slightly higher level. So trying to solve the problem by ensuring that there is that control and that input from a governance perspective, I think is the right way to do it. But we have to recognize that, again, there is something by its very nature that at a minimum, I would even say at the county level is where the service needs to, because it's not just the disparity in services. I know there's a new report out that talks about, we talked about this early on, the life expectancy of Hoosiers. And so what we're trying to do here is really ensure that everyone, every Hoosier has access to that minimum set of protections. And so that's why I think moving it up to that level, understanding the grandfathering consideration is important. And I think it's a great solution for that, to provide that.
We've definitely gone well over the time
Yeah,
we had allotted,
sorry.
although we knew that we would probably
We
take
might.
more time for this. Do you have?
The last thing I think we should probably talk about is the local health board and that its composition. We recommended a couple of changes here. One is it was very much you have to declare you're Republican or you're Democrat in order to be on the local health board, and you had to have no more than 4 of one particular party. We do know from talking to some people, they would like to serve, but they serve in a position in their community that they feel like announcing that they are definitely Republican or definitely Democrat. That seems to be a conflict of interest for them. Kara, I'm going to share that. You shared that with Shane. And I think that there are also people that are truly independents out there. And so we wanted to allow for, a couple of independents or people that would say, I really want to serve. This is my interest, but I don't feel like I'm comfortable with that. So I wanted to throw that out there as a change. And then the 5 people that would be appointed directly by the commissioners. We recommended that at least 2 of those are physicians, if possible. We know that local health boards have had trouble getting 1 physician across the state of Indiana. So I don't think we can, put that in stone, but it recommended of those. And then we added L, which is a professional from the public health field, would qualify greatly, like someone with their master's in public health or an epidemiologist would be a wonderful addition, I believe, to a local health board. And then 2 and 3, I think what you're saying there is that a representative of the cities, an elected official from the cities and or the county council. Is that? Well, that's what I didn't.
Would have an appointment to the board, not themselves be on the board,
You
Okay.
think that's a violation of the lucrative office?
isn't it?
I
that's
don't
what I
think it
don't like.
is.
You don't think it is? To
No, I
serve
don't
on
think
a, really?
No, I don't think so. You have all kinds of committees at the county level where you have elected officials that serve on different committees with other county officials. I mean, we need to check that, obviously, that we want to verify that.
Yeah, it was determined locally for us, so that's where I went for that. But if that was an incorrect attorney interpretation, we'll get that corrected. But we weren't allowed to do it.
Okay, so we'll take this back to our legal team.
Yeah,
then. But
we
is
can
there
work it.
other general discussion about this?
Well, just the clarification, I think you said and or, but I think you were saying 1 county level elected official and 1 municipal.
I thought that would be a good thing to do somehow or other, to have a city representative or person, I guess I thought elected, but if it has to be appointed, to get them in the conversation. And then secondly, I thought that there should be somebody appointed by the county. And I went through all kinds of iterations, whether it should be the commissioners had the appointment, whether it should be the council had the appointment, whether it should be the circuit judge, whether it should even be the governor, or whether it should be the mayors all get together and they agree on somebody. So I don't have I'm messing up Chris's attempt to have some actual language here, but I think we need to work on it a little bit more and use some of those suggestions. And I don't know, if you don't have a thought here today about how you feel about these, since this is the first time some of you have heard this, maybe we could, Shane, maybe we could do an email response and people can try to give you their thoughts about some of these things, in addition to the discussion we're going to have here today.
So we could confirm the legal aspects of this.
Yeah, and confirm the legal aspect of it. That's right.
Mark and then Kim?
Again, I just want to reiterate that usually, as I understand state law, anything under 70,000 residents in the county, the commissioners are doing all the appointings at this particular time.
Okay.
And so we are alienating a lot of our municipalities or our constituents. So it's very important that we really look at this and figure out a way to get representation in a positive
We
way.
can lay it on the governor and then he can change his recommendation before he goes to the legislature.
Kim, and then we need to move on.
Comment
Yeah,
was just
go
that
ahead.
if available seems very loose in terms of language of 2 positions. So I don't know how to do that, but I feel like it opens it up to a lot of challenge if that's the word.
Okay, well, willing and available. I mean, we literally can't find one physician sometimes to serve on local health boards.
Yeah.
So what's your suggestion then? Don't
Recommends to.
recommends to, okay.
I feel like that, I don't know, I'm not a lawyer, but.
Yeah, okay. Okay, we can certainly change that.
Okay, Congresswoman.
Well, as I thought about the 2 counties that have already have their independent municipal, Lake County and Hamilton County, both counties that have large cities in their counties. I mean, multiple large cities in their counties. And I'm just trying to envision the mechanism of Lake County and Hamilton County picking who gets to serve on the local health board. It could be really difficult. And then you have small little towns with mayors in these counties also. And I don't know if there's any precedence. Do you know, is there any precedence for mayors of counties coming together to choose, you know, a representative? I'd be curious what mechanism, just because I worry about our really small town mayors saying, hey, it's always going to go to the big city mayors, or the big city mayors really not maybe necessarily getting along. And or so between these types of counties.
It's very clear in the state statute who has the appointment authority now. And so what we're talking about is, are there people that are left out that needs a voice, that should have a voice? And I think on the, on the incremental side of things, it's probably going to be the smaller municipalities that are the largest in a small county that needs voice. But other than that, I think the large cities, it's very clear who has appointment authority for those county health departments. And I also agree with Mindy that the elected officials have been appointing themselves to the health board because they have statutory authority would be probably violation of the dual office holding law.
So Shane, can I do a quick check? I mean, we're way over time. Should we, were you going to do some emailing? Did I hear?
Yeah, I think we'll try to synthesize this conversation, send some stuff out. As well, in advance of the June meeting. So any formal action will have to be taken at the June.
Okay. Can folks hold? Is there anything absolutely burning, Carl?
Yeah, I just want to ask one other comment. Part of the experience I had in St. Joe County is that the mayor of South Bend was the only official who appointed a Black member of the Board of Health. And one of the things I don't know is what the race ethnic composition is now of these boards. I do know that Indiana is becoming more diverse, and that somewhere along the lines, we need some incentive, if you will, to assure that community representation exists in the appointments that are made. Now, I recognize that elected officials get to make that judgment.
Right.
But in view of our effort, our desire for more health equity, and view of the fact that we're going to be addressing social terms of health, somehow the question of representation ought to be also addressed in the broader issue of who's appointing them. I don't know if because when you look at the professions, and this way in St. Joe County, the pool from which you can pick tends to be underrepresented by people of color anyway. And so there's a stake for people of color that's just not recognized that I think is important to go forward.
I agree. It's got to be a way to, without requiring it and creating a legal mess, to recommend strongly a representation or some way in which to recognize the importance of diversity among our boards.
Yeah, so this has actually been a fascinating discussion and it's complex, but I think it's incredibly important. Then this representation is really critical, especially with the aim of why all of this work is being done. So Shane, we'll look to you to work on pulling some of this together and we'll have other meetings to come back before obviously finalizing. So in the interest of time, now that we're well past the original time, I'd like to invite Dr. Fennell to come and she's going to discuss with us draft childhood and adolescent health recommendations. And hold your questions. We'll have Dr. Fennell go through her presentation and then we'll get into discussion and questions.
Wonderful. Can you hear me okay? And like that. Senator Kinley, Dr. Monroe, Dr. Box, Congresswoman, and Commission. I'm here today, back from February, to talk about childhood and adolescent health integration, the proposed recommendations. I want to bring you back to February, then when we talked about that Indiana now ranks number 36 in the nation for child health. So that's where we start.
Can you speak up just a little bit, Maria? I'm so sorry.
It's okay. A little better there, I think. Okay.
You got to be right on that mic. Yeah.
Yep. Going to the overall goals of our work group is to improve student learning by mitigation health barriers, enhance early childhood education and school-based health education, prevention and wellness activities, improve the access to child and adolescent health care while protecting parental and guardian consent, and then reduce childhood injuries and fatalities. Here are the work group's draft recommendations, and I'm going to go into each of them and talk a little bit about proposed action items. Increase the availability of school nurses. Increase access to service to support whole child wellness. Support evidence-based health education and physical activity in schools and early childhood education settings. Support access to health screenings and services that can be appropriately delivered in schools and early childhood education settings while maintaining parental and guardian consent mechanisms. Reinforce meaningful implementation of school wellness policies. Support the development of school-based health centers. Inform the provider community on ongoing public health initiatives and address the childhood injury and violence prevention in Indiana. So draft recommendation 1 is to increase the availability of school nurses. As you may recall, we know that school nurses are correlated to overall cost savings, reduced student absenteeism, and improved vaccination rates. In Indiana, the requirement in regulation is that it's 1 school nurse to 750 students. We know that while we don't have exact count how it looked in each part of Indiana, we know that that 1 to 750 is not always met. We also know that school nurses often fall into the category of school staff and not into certified staff, which affect their reimbursement. So potential action items here would be to establish a dedicated funding mechanism for school nurses and to implement policies to support school nurse recruitment and retention, such that, for example, addressing the low pay and incentivizing school nurse credentialing. Our next recommendation is to increase access to services to support whole child wellness. These assistance services are the services that prevent, or they're set in place to prevent problems that interfere with student learning. The national recommendation is to have a school counselor for 1 to 250 students. We know in Indiana that currently it looks like we have 1 school counselor to about 475 students.
475?
475 in Indiana. So potential action items here would be to implement policies to reduce the school counselor, social worker, and psychologist to student ratio. and consider a dedicated funding mechanism also for these personnel. For both school nurses and for school counselors, we know that they're measured based on their educational outcomes, and the way the funding comes into them, they of course often have to make that a priority. So for both these groups, school nurses and school counselors, it becomes sometimes difficult for schools to make this a priority. Recommendation 3 is to support evidence-based health education and physical activity in schools and early childhood education settings. So schools are required to include a curriculum on lots of different health matters. Some of those curriculums are required to be evidence-based, but not everything. For example, hygiene is not required to be evidence-based curriculum. So some potential action items would be to make evidence-based curricula on health matters available for schools, for all schools in Indiana, and make also for our early childhood education settings for them so that they can access them and make sure we sort of elevate the importance of them being evidence-based. Provide technical assistance to implement these curricula, and support the schools and early childhood education settings in identifying opportunities to increase physical activity during the school day. We know that physical activity is correlated with better student outcomes, including educational outcomes. Recommendation 4, to support the access to health screenings and services that actually can be appropriately delivered in schools and early childhood education settings, while of course maintaining parental and guardian consent mechanisms. Potential action items here would be to make best practice resources available for school and early childhood education settings to access. We heard loud and clear that the variation how this is done and the access to curriculum, that it sort of varies across Indiana. Convene a representative work group comprised of schools, community-based organization, and clinician and public health leadership to identify best practices for various communities. And support policies to increase the availability of nutritious meals in schools and early childhood education settings. And our stakeholders particularly pointed out that for our early childhood education settings that are not licensed, that are maybe private, church-based and so forth, that the access to actually be able to provide nutritious meals is often a problem and sometimes a financial problem. Recommendation 5 is to reinforce meaningful implementation of school wellness policies. This is important from the standpoint that federal law actually requires each local education agency that participates in a federal child nutrition program to establish a wellness policy. So those policies exist, but it was loud and clear that we heard like sort of implementing these policies is where it becomes difficult. It's difficult from a resource standpoint and sort of just having the staff to do it. So the action items around this would be to fund and leverage Department of Health or Department of Education and community partners to collaborate with school districts regarding the benefits of evidence-based wellness policies, and fund the technical assistant to implement evidence-based school wellness policies. Incentivize school districts to prioritize wellness policies via the school grant processes. There are some limited funds for these school grant processes to implement the policies, but it's very limited at this currently through the Department of Health. Recommendation 6 is to support the development of school-based health centers. As you may recall, when we had this conversation in February, there are school nurses and then there are school-based health centers that function a little bit more like freestanding clinics. There may be the best option for some communities. And if they are, we should provide technical assistance to school systems interested in developing a school-based health center, but also make sure that we leverage best practices from established health centers and in compliance with parental consent requirements. In the sort of aftermath of the pandemic here, we know that telehealth has played a role and making sure that if school-based health centers are established, that they're really following best practices in their implementation of those, I think would be very important. Recommendation 7, inform the provider community on public health initiatives. What we heard from our stakeholders was that the provider community they're not always informed on the ongoing public health initiatives and sort of how to access resources. Potential action items would be to develop technical assistance framework for Indiana healthcare providers on public health best practices and available resources, increase the provider awareness of public health initiatives, opportunities and requirements, and address practice variance across the state on public health matters. Last recommendation is to address childhood injury and violence prevention. Accidents is the leading cause of death among Hoosier children age 1 to 19. Suicide is the second leading cause of death for Indiana youth age 10 to 14. Potential action items here would be to establish an interprofessional coalition of experts focused on keeping youth safe from unintentional firearm death and suicide. Ohio has such a model that has been successful. Action item 2 would be to fund and leverage Department of Health to develop policies to address safety issues and increase equitable access to safety equipment shown to significantly decrease child injuries. Some of those items could be bike helmets, cabinet locks, stair gates, firearm locks, things like that. Thank you.
Thank you. Thank you. So questions? Carl, look like you're geared up.
Yeah, I was
Go.
just going to ask, I don't think there's anything controversial in the recommendations, but I'm not sure whether you're giving us a target. So for example, with school nurses, is it thinking that we should, within 10 years, have achieved the 750:1 ratio or some parameter?
I think maybe the first goal should be to figure out where we are. We actually don't know exactly. We know we're not at 1 to 750, but it varies across Indiana. The very first goal would probably be to figure out how does it look across Indiana.
Well, I'm
It's
getting at,
been-
would it be in the best interest of the state to have a ratio of 1 to 750 for our children in school?
It's been a difficult number to pin down, especially since the pandemic, because just like nurses everywhere else, they've lost a tremendous number of school nurses. So their summer report that they do for the schools, we will see how many school nurses actually report and have that hopefully this summer, midsummer time.
Right. What I'm just trying to get at, should that be a standard that we're striving for as a state? Should that be part of the aspiration that comes from this commission?
Absolutely.
Mindy?
I have a question. I don't know how like non-public schools factor into a lot of the current requirements for vision and all those things. Like, do you know? So if you were in these statistics you're talking about, is it all schools or is it schools with corporations or districts?
I would have to take that back to know if any of the bigger private schools are included or not.
I just think there's a lot of private and parochial schools that I just wonder how they factor into this. I know in our area, there's so few nurses among them, and they do some services at a lesser level, probably because of that. And I wondered if we wanted to make sure that we include that in the thought process, if it's possible. I don't know school health enough to know that. I just know that there's a disparity.
And I think it would be great to point out the recommendations for the state, what the state is recommending. I don't see that we would have a lot of control over that.
Dr. Welsh?
Lots of really good stuff. I applaud you for your recommendations. I could give something positive on each one. The school nurses, working 2 counties in a variety of schools, I really see the positive side of a strong school nurse program. And it gets back to some of the things we talked about on other sessions about mental health and telehealth and how we can reach those kids more effectively. On the activity, I would draw on as many on recommendation 3, would draw on as many folks as stakeholders as possible, particularly Department of Education, but you can get IHSAA, you can get the Family Practice Association, the Peds Association, they would be right there with you to help with increasing activity. They're talking about this all the time at the professional organization level. On recommendation 4, I would add something about nutrition education. The schools that have had positive effect not only improve the nutrition in their meals, but they incorporate it into class gardens and educating what's the better way to choose. So the education and being in a rural setting involving 4-H, oh my gosh, and the county folks, they would love to be involved with this because they have a lot of information in this area and a lot of interest in this area. Gotta love the wellness and any wellness things. Recommendation 6, another opportunity to push for telehealth and particular mental health access. That's really shown in the last 2 years a lot of deficits in accessing mental health to the students. On the public awareness of public health initiatives, again, we can have folks that will step up and help us with this. I think I can easily speak for the State Medical Association and some of the specialty societies. They would be glad to help push out our public health initiatives to inform their members and their non-members of what the state is doing and how it can help in their community, and maybe invite them to step up at their community. Maybe they could serve on a health board, who knows? or help with be a resource to the local schools. I know different times I've been involved with local schools and helping them with their public health education or these other things that we've talked about. On 8, very important, reducing fire injury and violence prevention. Farm-related injuries is something I would put on your radar, and that's been something big for me. So again, we can work with 4-H, we can work with Farm Bureau. They will be big on trying to reduce injuries because that is always really tugs at your heartstrings when a youngster is hurt on the farm, just trying to help, grandpa or their parents. The Trauma Care Committee, I think I can speak for them, that they're all about reducing injuries. So they would be another stakeholder that would be able to help us. Reducing fire injuries, that's actually something that's big on a number of different organizations fronts, AMA, American College of Surgeons. Any trauma center has part of their core things to work on is reducing injuries in their area. So there's good resources and a lot of these professional organizations, the State Medical Association, the Family Practice Association, PEDS, probably ACOG, I would suspect, if I recall correctly. So we can also get our local churches and WISE organizations to help with. They're all about wellness. The WISE, for instance, about wellness, reducing injuries, and how to do these things correctly. So lots of good stuff, but I see lots of opportunities here. And the other on the reducing the firearm related stuff, I would connect with DNR. They've got great programs, instructional programs, and there's a lot of groups around the state that will be happy to expand their firearm safety instructions. There was a time when even schools had their own marksmanship groups. I'm a history buff, so there was a time when in the 19th century where people were really good, very proficient and safe with firearm use, and that fell off. So then we got to wars and people realized people weren't as proficient, so then they brought some of those things back, and then that kind of slide. So in a rural community, there's a lot of interest in firearm injury, reducing firearm injuries and gun safety. And I think that's something that we can get a lot of stakeholders to help us with. But a lot of good stuff. I applaud you for the information.
It's too bad we don't have enthusiasm on the commission. All right, Dr. Kane, and then to Dennis.
One thing I wanted to, Dr. Neal, that came up, did you look at the vision? So we know we're required to do vision screening of children in school, but where we fall short is after we identify the problem and that child needs glasses, a significant number of the parents says, well, I didn't have to have glasses when I went to school. And so they do not provide the corrected glasses for these children. So they continue to have lots of difficulty in doing their homework because they can't see the board, they can't read the textbook. And so I don't know, how do you address that? We provide a grant to make glasses for the kids who the parents refuse to buy the glasses for, but I suspect there's a significant number of children in these school systems that they identified that they need glasses, but they don't have corrective resources.
Thanks.
I appreciate
So,
that
think,
comment. Oh,
Dennis, I think you were next, correct? Dennis and
Yeah.
Hannah.
Go ahead. You were gonna make a comment. Go ahead.
I was just going to answer that. At this point, we looked at sort of ideas for how to get screening done, but I think the point of sort of there's a next step there in order to make sure children can actually see, of course. is
Many
like,
schools
you know,
are just getting
there's-
a waiver for the screening. They're not doing the visual screening because our visual screening code is, as my husband said, this requires a dilated eye exam to do this, and this is ridiculous. So
Well,
I know
if that's
something.
the case, we haven't been doing dilated eye exams.
No, but if you just, anyway, I think what Maria's trying to say is we've got to start with the screening and make sure that every kid's getting screening. But then what you're saying is the kids that are getting screening, are they actually going then and getting the glasses?
Yeah, there
And
needs to
we've
be
got,
action if there's findings, right?
Right.
Okay, we are tight on time, so we'll go quickly with
Okay.
questions,
I'll
comments.
try to be real quick, but I want to make a political comment. Dr. Welsh, if this was your primary election group here, you would be elected. I'm sorry you lost your primary.
thank you.
That's good.
But real quick, your comments on the school-based health centers and then the school nurse situation as well, I think again, and I don't know how it fits in or works into this, but go back to working with the healthcare providers that are in the communities so that working together with them, I think would be a way to accomplish this. And actually, as I've thought about it more sitting here listening rather than at home, in some of the rural areas, these school-based health centers could be a huge help to local community to provide really good healthcare services to the kids in that community. So that could be a boon. And I'm sure that the hospital provider systems are more than willing to work together. So.
Very good. Hannah and then Brian.
I will be very brief, but two things. You mentioned very quickly the credentialing of nurses, but I also think behavioral health professionals within our education system. So I want to make sure everyone understands what that means. If you go to IDOE's website, there are provisions by which a nurse who has a MSN can actually get credentials through our Indiana Department of Education. A credentialed nurse qualifies for a higher wage or rate than a non-credentialed nurse. The reality is we don't necessarily need MSNs for every 750 people. That would be wonderful, but we're not going to achieve that. So if we're looking to address low pay wage issues, perhaps we need to look at that code and see whether there's any opportunity to have nurses that have an ASN possibly, or any registered nurse be able to obtain an Indiana educator nurse credential, what they call professional nurse educator. That's number one. And you kind of referenced that, but I wanted to make sure people understood, because I know we're also potentially looking for opportunities that are lower hanging fruit. The other thing that I did want to mention, I know that the Children's Commission has worked for several years and there has been legislation passed regarding Medicaid reimbursement for qualified school health services. And the last two sessions we've seen legislation on that, and it basically authorized the state to go after a state plan amendment to cover a greater number of services as qualified for Medicaid reimbursement. Is that an opportunity for us to get more health service funding for schools? And what I'll say is schools are already covering to some extent these services through their allocation appropriation already. So when they're able to get reimbursement for greater services, those funds come back to the school as unencumbered reimbursement, which could potentially theoretically be used to support wellness plan adoption, buy glasses for kids who need them, run those types of programs. So I just wanted to, there's some potentially some policy opportunities, intersections that we could leverage for this.
And I wanted to echo Medicaid. That's what I was going to say. I think we talked about it, Dr. Fennell, during your presentation. So I think we should, Medicaid strategy and how we can help schools kind of scale to be able to bill, because that's difficult. We heard about that with departments. I think that's important. And then just secondly, that nurses and the availability of nurses. We also need nurses for the public health offices, and we need them in the hospitals as well. And so to the extent that we can make this our initiative here, part of maybe even a broader initiative in the budget year to work with our institutions of higher education to increase the supply of nursing just across the board. If there's any federal money left, I know Michigan just put something like $300 million of ARP money, I think, into workforce. So we're going to need a big investment to be able to produce those providers. But great job.
So thank you all. Paul, you've got the last word.
Two things quickly, I hope. One is related to oral health. And, again, one of the leading reasons for kids who are unable to concentrate or who may be absent is because they have a toothache or they have oral health problems, and we have uneven distribution of oral health services that are available. There are a number of public health solutions that ought to be considered, including sealants and screenings and a whole host of things. And I think it's pretty typical. We frequently leave out oral health, and it needs to be included. And then secondly is the issue around childhood obesity, which is reaching relatively epidemic levels, not only here in our state, but across the country. And we know that there are policy-related levers which have substantial impact. It's not only as you mentioned, in terms of the availability of nutritious meals, but it's also reducing the availability of non-nutritious items, which include the fact that we now are beginning to see more and more kids who get their primary nutrition from a vending machine, whether it's in terms of empty calories from sodas or from other snacks that are nutritiously deficient. And I think, again, from a policy perspective, there's a substantial opportunity for improvement. That, coupled with issues around physical activity, I think are really important. And I wouldn't want to leave the opportunity, because you've got such a wide berth of great things in this program. I would want you to try to put those two things in as well. Thanks.
Thank you. Thank you. So actually the last word goes to the Congresswoman.
Sorry, there were just a couple of things, and thank you for bringing up childhood obesity. I was going to bring that up. But one of the public comments that came in focused and suggested things like healthy food financing initiatives at the state or local level, obviously supporting the federal funding of school meals, community health, and all policies. I'm not something that maybe we might want to discuss separately than this, so that I think is very important. We focus on nutrition. Something that doesn't come through and was also brought up in public comment at some point. There doesn't seem to be any focus in these recommendations on those with special needs. And there are so many kids. I'm the mother of a special needs teacher. There are just so many kids in our school systems with special needs. And I feel like we have not really, even on either when we talk about councils and additions, that we always have to be thinking about people with special needs. And I don't know that we have enough yet. When you brought up classes, I thought, and people who can't hear, but then also other just special needs. I'd like to see a little bit, something brought up about that. And then finally, the last thing, when we talk about injury prevention and we talk about hospital systems and provider communities being engaged in this, I have been approached and wonder about kids who live, we always focus on, and Brian's not here, where is he? I wish he would come back, on Indiana hospitals, but we have hospitals, so I'm thinking Lake County. Many of those kids might be serviced by Chicago hospitals. Kids down on the river might be serviced by Louisville hospitals. And so not everybody comes to Indianapolis, maybe they do, but they don't, okay? They go, you know, if you live in a border community, you're going maybe to Cincinnati or to Chicago or to Louisville. And if we're kind of bleeding, we are one of the only states doing this public health commission overview, okay, of looking at that. And so I think we need to think a little bit regionally, not just on behalf of Indiana and the kids who live in those border communities, but somewhere where we might be focusing a bit on taking a little more regional approach with larger hospitals. And what is their role in especially adolescent and childhood health?
Well, thank you. Thanks to everyone. I mean, this was tremendous input, obviously some additional items that folks want to consider including. So we'll come back to that, right, Shane? We'll Dr. Fennell, thank you for your presentation and your input in, coming back to us with thoughts around the recommendations based on all the input today. So
Thank you.
thank you. Thank you. I think we do need to move on. That was, we're not quite ready for a vote, but there was a lot of enthusiasm. I would imagine a lot's going to be included in our final recommendations in that category. So we're now going to move to the draft emergency preparedness recommendations and invite Mr. Stephen Cox, IDHS Executive Director. Welcome.
While Shane's getting that done, good afternoon, Dr. Monroe, Senator Kinley, Congresswoman Brooks, Dr. Box, and members of the commission. Thank you very much for having me again. As you all remember, I was here in March to present on emergency preparedness in the state. Our working group has several different recommendations based on Senator Kinley's request that we be a little more specific about the recommendations that we have planned. I would also like to point out Megan Lytle, who is the Director of Emergency Preparedness for the Indiana Department of Health, is here again with me to help answer any questions associated with her section. As you remember, in March, Dr. Kaufman, who is the EMS Medical Director for the state of Indiana, was with us to answer EMS specific questions. Since March, Dr. Kaufman has moved into the private sector and is no longer with the state. And after a selection process, we have elected to hire Dr. Eric Yazel out of Clark County to take on that role. We're really excited about having Dr. Yazel with us. However, he is not scheduled to start with the state until May 31st, so he is not with us today. I will attempt to answer any questions associated with EMS if anyone has them. In the interest of time, I'll get started with the recommendations. The overall goals, just like Dr. Fennell's presentation, we wanted to make sure that we structured this in the same fashion so that the commission has kind of a standardized approach to the recommendations. So the overall goals that we had with our working group were to ensure connectivity and facilitate information exchange and preparation for and during public health emergencies, to enhance local health departments, the Indiana Department of Health and EMS readiness, and to improve the scalability of emergency response efforts beyond the local level. And within those goals, we had 5 draft recommendations, and those should all be in your packets that you received. So the first recommendation is to increase utilization of the Indiana Department of Health's EM resource tool across all Indiana hospitals, local public health departments, first responders, and applicable government agencies. The second recommendation is to require local health departments to participate in the CDC Public Health Emergency Preparedness, or FEP, grant program. The third one is to enhance the Indiana Department of Health's emergency services and supplies capacity. Number 4 is to ensure local level EMS readiness through the expansion and sustainability of the EMS workforce. And number 5, to improve regional coordination efforts to ensure seamless emergency response. And then within each of the draft recommendations, we also have possible action items that I'll go through. So draft recommendation number 1 was to increase the utilization of the Indiana Department of Health's EM resource tool across all Indiana hospitals, local public health departments, first responders, and applicable government agencies, with the possible action items being 1, to include EM resource participation as a condition of hospital licensure. 2, to ensure the awareness and training on the use of EM resource and web EOC of all relevant partners. 3, to secure funding and infrastructure for EM resource management. And then the 4th is to require local health departments to utilize EM resource or the EM resource tool. Draft recommendation number 2 is to require local health departments to participate in the CDC Public Health Emergency Preparedness Grant Program, with the possible action items of 1 being a requirement that each local health department to have a FEP coordinator, and that's at approximately a half of an FTE minimum per local health department. And then number 2, to provide technical assistance as needed for the grant activities and reporting required of that program. Draft recommendation number 3 is to enhance the Indiana Department of Health's emergency services and supplies capacity. The number 1 action item would be to maintain the Indiana Department of Health vendor contracts that can be activated during a public health emergency. With number 2 being to evaluate the need for a state strategic stockpile to ensure the availability of personal protective equipment or PPE and medical countermeasures or MCMs. Number 3 is to engage healthcare coalitions, local health departments, and statewide partners to develop strategies for extending PPE and MCM supplies so that both are available when needed most. And then number 4, to direct the Department of Homeland Security and the Indiana Department of Health on coordination of public health emergencies through training exercises. Draft recommendation number 4 is to ensure local level EMS readiness through the expansion and sustainability of the EMS workforce, with action items as follows. Number 1, to conduct a needs assessment of specific EMS gaps in local jurisdictions. 2, to ensure funding and prioritize recruitment to address workforce shortages in EMS, particularly in underserved and geographically remote areas of the state. We know those are particularly affected disproportionately. Number 3 is to establish long-term promotional and retention plans for EMS personnel. And then number 4, to explore ongoing training and expansion of community paramedicine programs. The 5th recommendation is to improve regional coordination efforts to ensure a seamless emergency response, with the possible action items being 1, to evaluate stakeholder engagement processes to redefine the IDOH emergency preparedness districts as they stand today. And then number 2, to evaluate stakeholder engagement processes to redefine roles, responsibilities, and authorities of regional partners. Those are the recommendations that we have on the emergency preparedness side of the house, and I'm happy to answer any questions that the commission may have.
Very good. Thank you very much. Very thorough and clear. Questions? Dr. Welch.
Surprise, surprise.
Yeah.
So great
Yes, sir.
ideas. Just some suggestions. With the getting to recommendation 2, might be able to, I don't know if we can do it at the local level, the coordinator, but that would certainly be a district level. Getting a coordinator and helping with the training is, the grant is fantastic. On recommendation 1, I would love to get access to the login information to learn more about myself, and then maybe have some additional comments for you for the EM resource. And on the hospital licensure, I would defer to Mr. Tabor on that. But in the second part of recommendation 1, the training, I think that would be right down the alley of the hospital association, medical association working together to get training out to our members, because this is gonna work if we get the hospitals and the docs and the local stakeholders working together, and the health departments. On recommendation 3, again, more opportunity for the medical association, hospital association to work together, as well as American College of Surgeons and the Trauma Care Committee. On the strategic stockpile, yes, please. But we can also have training. Every time we have something happens, we get an uptick of this information, and then the stockpiles local stockpiles kind of disappear. So some training on how to maintain your local supplies so that they stay ready to use. 2 years ago, we were fortunate. We still maintain our stockpiles from the previous outbreak, and we were able to get N95s to our local EMS. Recommendation for, yes, please. I've actually talked with Professor Donald Heidi at Ball State about this very issue, how we can improve the pipeline for EMS personnel and retention, expanding cadet programs that are happening across the state. Talking with Chris Lowry, used to be with Ivy Tech. They've got programs of that in different parts of the state, but we can expand that. We can connect with the schools. We can connect with 4-H and Farm Bureau to line up the folks involved with them, so that particularly rural has more. They're hurting for EMS. They're hurting for first responders, and this is an area that we can work on. And the last recommendation, re-looking at that, I can tell you. Again, I'm going to call on Dr. Weaver for the Trauma Care Committee and the American College of Surgeons Indiana chapter, ISMA, that I'm sure the Hospital Association would be happy to work with, because how these districts are going to work effectively is going to be tied into our first responders, to our local hospital, to the folks that are interested in this. And it gets back to regional partners that we've talked about in other areas. Thanks.
Wow. Okay. Now we have Mindy and Dr. Howerson.
I just have one. Would there be any thought or consideration on the general recommendations on page 3, number 2, for instead of requiring health departments to participate in the grant, what about the goals that are part of the grant being met versus forcing us into a grant that some counties won't be allowed to do, won't be able to hire a part-time or a 0.5 FEP coordinator. The bottom line things are the things you want done in the grant, right, Megan? Could it be something more along that line and then make us achieve that with hopeful new funding coming in versus saying you must participate in the grant? You know what I'm saying?
I think I'd have to look at what you're talking about, Mindy, and look at what the current requirements are for those grants. I don't want to commit myself one way or the other on that because I don't know enough about that, the specifics of it. So Megan, do you want to address that?
Yeah, I mean, I think Mindy is on the right track, which is right. I think that the goal would be that there would be somebody. I think the goal would be that there would be somebody dedicated within each public health department that focused on emergency preparedness, had that continuity of operation and planning and training and exercise, knew who to call, could tell others who to call in the emergency. A lot of times that activity is absorbed by many other responsibilities, and to have somebody that was focused on that would be, I think, ideal.
And how does that fit with the grant comments then?
The grant requires you to attend meetings when those meetings are scheduled. It requires you to turn in an attendance list, little things. There's a lot of it, but in the end, what you're wanting is the cooperation of planning, the plans that are being written, the participation in the drills. Can you skip some of the stuff that makes it very hard for some of us to do, that to force us into a grant? Just require us to meet your deliverables.
Yeah, and I think that Dr. Box, it's also about not necessarily participation in the grant, but that there is local health department personnel assigned or dedicated to these activities. And the grant is a mechanism by which we can provide the funding and we can meet the requirements of our federal funder as well. It all kind of comes together regardless of if the county or the health department participates in the grant, so long as we can report up those things. But in the actuality of the response and preparedness for Indiana, the things that are being done and having somebody dedicated to doing those things is my goal, would be the goal.
And for me, it would be having somebody dedicated to be engaged with the other counties around them and sitting at these, healthcare coalition meetings and making sure that everybody's engaged there and engaged and involved. So we can have some more discussion around that for sure.
Dr. Halverson, and then it's actually Susan, because she's in my blind spot and I keep, I keep acknowledging and then losing, then Kara, and then Kim.
Great job on this. I really appreciate its thoroughness. I had 3 recommendations related to draft recommendation 4 on EMS readiness. And I think it goes to something I brought up the last time, I think after your presentation, which is the American College of Surgeons review of the state trauma system. I think it's long overdue. And I think that needs to be undertaken and recommendations need to be made and followed. Secondly, issues related to increasing rural participation in the trauma system, in particular as it relates to training and as well as the trauma registry and its ubiquitous application throughout the state. I do think that there's a disproportionate rural disadvantage, and I do think that thinking through a strategy to increase hospital participation in the trauma system would be really important. The last thing, which I think is a substantial issue, particularly as it relates to our ambulance services and EMS, and that's the requirement. I would suggest we need to consider a requirement, a mutual aid requirement, so as to create the opportunity for patients to actually be served by an effective trauma system. And for all the reasons I think we talked about at the last meeting, I think we could be helpful by actually having policy guidance that actually requires that the EMS providers do the right thing to support the systemness, which ultimately gets subverted when we don't have mutual aid requirements.
Very good.
I would go to draft recommendation 3 on, and would strengthen the language on evaluating the need for state strategic stockpile. I'm going to advocate we need a state strategic stockpile. In 2020, all we did from a congressional office was fielding calls from local health, from everybody about needing PPE and not sure where we were going to be in getting medical countermeasures and the testing and all of that. And I think there's going to be, and I was involved in what was called PAPA, the Pandemic Hazard Preparedness Act, and trying to strengthen the strategic national stockpile. We had always focused on medical countermeasures. We didn't focus enough on testing and diagnostic testing, on therapeutics and on PPE. But we also, it's never going to have enough stuff in it for the country ever. It will not, and so if the states don't start to step up, and every state either be coordinating with all the hospitals and all the medical providers and all the everybody else and run that coordination, we've got to have a state backup. And I think all states are going to need to, and I'd love to see Indiana lead the way. And do other states, I don't even know if other states, Judy, you may know if they have state strategic national stockpiles, but traditionally they have not.
Yep.
They've relied on
Most
the
do
federal,
not.
and we have learned it's never going to be funded enough for what we just went through.
So, ma'am, if I could address that for
Yeah,
one
it's
moment.
big funding. That is a concern.
Absolutely.
And I'm not saying, but what everyone was fighting each other to, and calling other countries and, trying to, the supply chain was horrific. And so I think we have to put some real resources to not evaluating the need. We know there's a need.
We're actually in the process as a state through the RFP process to create a statewide SNS. That process is ongoing right now. So that is being built out.
Well, then I think we definitely need to change, evaluate the need to support the creation and, building of, I mean,
And
unless you all
Yes,
disagree.
ma'am.
huh?
And maintenance of it.
Which is exactly. Megan, you want to talk to this?
Yes, so thank you. We do have a process we're working on an RFP for our state stockpile. The request would be for funding to continue that beyond the first 1 to 3 years. We have identified funding for the first year, but it would be that beyond that we need that continued funding. We have the processes. We know what we need to do. We've learned based on everything you just said, and we couldn't agree more. It would be that support through funding that we need.
What kind of funding are you talking about? Are we allowed to
It's
ask that?
significant.
Yeah,
Okay, okay.
thank you.
Shoot, I was gonna give him a number.
And if I-
It'll be
and if-
significant.
But if I could also
I knew it was
add to that,
11,000.
Dr. Halverson's 100% right. A big portion of that is the maintenance of that stockpile.
And that is.
And that's a
all part of the
huge part.
RFP.
Yeah, that's a huge portion of it and
Changing
it's expensive. So.
What I don't think a lot of people realize and what we learned, things had expired in the stockpile. We need a system where things are moved out, in the last several months to locals, to make sure. So there's a lot that goes into the stockpile that we learned through this. But the state, the federal government, we can never count on them for what we just went through.
Okay, we had a few more. Carol, were you in? Yeah, I think Carol and Hannah.
Oh, sorry.
No, trying to remember.
It was going back to the grant, which I don't know anything about, just I'll preface that, but can a regional person suffice the requirement for that as opposed to each LHD having a 0.5? I mean, I don't.
I think that there is value and benefit in having a regional person that could help and assist and bring people together, like Dr. Box had referenced. Again, I think that there are proven response successes and opportunities for improvement in counties that we don't have anybody that is dedicated to public health preparedness and response. And that's why we landed on the need for somebody that is dedicated in every county, because everything's relative. What is big to Switzerland County is nothing to Marion or Hamilton, but it's still relative and it's big and it takes up all the resources that they have when it happens for their community.
I agree. I just worry that we're gonna get we don't have the resources today. And I mean, I assume that 0.5 is solely dedicated during that 20 hours a week that they can only focus on the emergency preparedness, and that they couldn't be utilized in other capacities and health department obligations as well. Like, that's the way I read that, but maybe I'm overreading.
The way that we have it right now in the FEP grant, so if you're participating in the FEP grant and you get the 25,000, so long as you're meeting the requirements set forth by the grant, then we're meeting our federal requirements and you're meeting the requirements of what we're putting out. And if there's time, I would say that community outreach and engagement and the different things that you can do beyond just preparedness also add to the value of that person at the local health department. So I would say they can do more than just, yeah.
Very good. Hannah and then Brian.
Yeah, I just quickly wanted to mention, I know that in draft recommendation for B was focused on workforce shortages. And I would ask that as we, as a commission, consider health workforce issues, that maybe instead of having health workforce recommendations in every single area, that perhaps we really do need to think about how do we do a statewide health workforce assessment that includes subsector analysis, right? So the public health professionals, the healthcare professionals, the EMS professionals, and come up with a plan so that we're not going in 6 different places, making requests for appropriation for health workforce recruitment incentives, right? And workforce development. I think it's going to be critical. We heard about it in the school health. We need to have a collective cohesive plan so it doesn't look like it's not a coordinated approach to how our health workforce needs as a state.
Good. Brian.
The EMS shortage has been mentioned. I've been on the road for our district meetings, and it's critical. And being able to build more aspirational things about a really well-formed trauma committee. We've got to address the EMS shortage right now. We have some great partners in the state, like Ivy Tech, that really came forward last session and said, hey, we think we can increase our classes by X. They've had specific numbers. Here's how much it's going to cost. I think talking to some of our partners about that too. How do we get, what's it going to cost to get X number of additional paramedics, EMTs trained? We really needs to be part of the plan if we're going to build kind of these other things on top of that. I don't really have an issue. I mean, I think as far as reporting and the licensure, I think EM Resource was a I think, a shining example of our partnership with the state during that, although there are some new federal rules with Medicare on conditions of participation. So I just want to make sure before we figure out where that goes, is it statute or regs, that it's linked up with what the federal government has proposed. And just regionalization, I think I'm on the same page with Dr. Veal about that. It seems like maybe if you could even pare back county, what's in the grant for each county, give them a more minimum set of duties, and then pool that money up to create regional. I've talked about regionalization before. I think this aligning with our hospital regions, other things like that, it's just, this is a prime area for regionalization, I think, based on my experience looking back on the pandemic.
Thank you for that. That makes perfect sense. So we actually are almost back on schedule. So do you have any last?
Dr. Monroe, if I could mention something additional, there's been a few recommendations in regards to EMS certifications of workforce. I agree 100%. Maybe that's, a broad overview would make sense. I'd just like to point out, Tuesday, I was in Lake County with the state fire marshal, and we met with EMS providers with Representative Fry, Representative Andrade, and a few other legislators, along with fire chiefs and EMS providers in Lake County. And one of the things, that it was a listening tour of needs that they had. And the number one thing that they came forward with was the lack of EMS certified personnel that they could grab as a pool to hire. And so what's happening is these agencies are hiring folks off the street without certifications or without the training, and they're having to provide that training then to their new employees. And I just want to, Dr. Kaufman, before he left, gave me some stats here. So in 2015, the state of Indiana recertified, or I'm sorry, provided there were 14,000 EMS personnel certified at the basic EMT level. And if you go down to 2021, that had dropped by about 1,500 certifications statewide down to 13,200. The reason I'm pointing out that specific certification level is just what Dr. Welch just mentioned. In most of the rural counties in the state, the basic level EMT is the level of certification that is providing EMS in those communities. And so while at the same time, the paramedic level, which is the highest level of EMS certification, has actually increased by a couple of hundred certifications over that same time frame. So it's disproportionate, and it goes back to what Dr. Welch said, it's disproportionately affecting these rural communities in a way that they have a smaller workforce to pull from. And one of the problems that was presented to us on Tuesday is these provider agencies who are now providing training to folks. And there's nothing against Ivy Tech. We in South Bend, we worked with Ivy Tech actually to provide certification training in a CTC program with high schoolers to be able to do just what you were mentioning. That was a great program. The downside is it used to be a hospital-based training program that basically was done full time. I went through medic school in '95, and I went through paramedic school in 9 months, and I was done because I was in school full time. And that was 5 days a week, 8 hours a day, et cetera, finished my clinicals, and I was on the street working. Now with this being moving away from the hospitals as a training program, and now it's a university-led training program, it's done on the semester level. And so as you're taking multiple classes here this first semester, then you have a summer break and you have to wait until the following semester or whatever. And it's taking longer and longer for them to get the training done. And that is one big problem that is occurring for these agencies. And we felt that crunch in South Bend as well. But additionally, there have been more and more training requirements with KHEP certification for these programs that require additional hours of training on top of the fact that it's become a semester-based program. So it's not uncommon for a fire department to send 3 individuals to paramedic school and not have them working on the street for 2 to 3 years now. That's, I hate to say this, but it's too long for them to go through that program, because there's a lot of time that's happening in there that are just breaks. And so it's become a problem. The other problem is there are fewer and fewer training institutions in the state as well. A lot of the hospital systems that used to provide this training no longer do so. And as I mentioned, it's fallen on the responsibility of some of the educational institutions who in some cases don't even have a program that exists right now. And so they're building them from scratch. In fact, we as the state right now are putting together a program that we can implement and train more people, because we have instructors on staff that can do so. Unfortunately, that's just going to be one program, right? So a more prolific way to be able to do this is absolutely needed.
If I can make one comment, I'm so sorry.
Yes.
This is a ripe opportunity for coordination and collaboration across government, because registered apprenticeships could be a whole nother pathway for EMS professionals to be doing work and learn experience to address our shortage. And so that just goes back to, we need a collective cohesive plan that can connect dots.
So is there can you take the police academy model and construct a theory or an idea about how you do that? Do any states do it that way? They have a statewide EMS academy, just like we have a police academy?
That would be a very interesting way to do it. The only downside is the amount of actual hours associated with a paramedic program. So the police academy is a 16-week program, not including weekends and holidays in that. And so I don't know right off the top of my head. I have to get back to the commission on the exact timeframe that would take.
Maybe that's as much as you can do to start with, and then you supplement it with further training after that. But 16 weeks at least gets them back into the job.
Sure. The thing we did at the South Bend Fire Department is when we hired these individuals, we had our own instructors. So we conducted our own training program, and we did it full time. And we had EMTs trained in about 2.5 months, but they were doing it again, Monday through Friday as their
It's hard to do that in White County.
I'm sorry, sir?
It's hard to do that in White County.
Well, sure, absolutely. 100%.
Very good. Well, thank you. Thank you very much.
Thank you.
Okay, we're going to move to our last topic here today, and we're going to invite Shane Hatchett to come forward, our Chief of Staff at IDOH, and he's going to discuss draft funding recommendations. So get to the money. Please hold your questions while he's discussing.
Yeah, I think very intentionally, we saved the best for last. No offense to my colleagues. No. Thanks actually for this opportunity, and good afternoon, everyone. I am excited for us to be rounding out this conversation today, because as we talked about earlier multiple times, a lot of what we're talking about really does hinge on, both defining what it is that we're going to be doing, what we're changing, and then how the heck are we funding it? Because almost everything we talked about has a price tag. So I do not purport that these recommendations will necessarily cover all of those aspects, but I think it's a good start down that path of level setting for this commission, what it is as a kind of benchmark, what we're looking for doing. As you'll recall from our November meeting when we discussed funding, we talked about the fact that Indiana historically and continues to do so substantially lags behind our peers as well as the national average. We reported that as of 2021, Indiana was at $55 per capita funding, and the national average is more in line with the low 90s, I believe $91 per capita. So approximately $35 to $40 below what we would see national averages. And when we're talking about what that covers, it's not necessarily reflective of some of these bigger ticket items that we've been talking about today, like increasing school nurse to student ratios, or revamping our trauma care system, or increasing access to EMS providers, or even a state strategic stockpile. So we have to bear in mind that those comparison numbers are truly tied to the 10 essential foundational public health services, or 10 essential services of public health, and represent what we're delivering today in traditional public health programming at the state and local levels. So first and foremost, I don't think this is a surprise at all, but we've got to increase and maintain our public health budget in order to be comparable to those national averages. This infusion of resources must also be used to enhance both state and local operations. And I want to be clear about that in order to raise all boats here, we've got to also include the local level. And so this funding cannot really be directed at one or the other, but it has to be both in a symbiotic fashion. It's also important to understand that these second, we want to make sure that we're looking at all available revenue streams. And so that also takes into account the conversation we've had relative to Medicare and Medicaid billing, especially for those health departments who don't have the resources to be doing that. And so what you'll find in here is some proposals related to that. And then finally, with this significant investment, and I know Senator Kinley and others have really talked about this, we have to demonstrate better outcomes and transparency. And as we've really dug into the data on this, it's not easily obtainable, and there are some challenges in creating consistent measures across different jurisdictions. And so one of the proposals we have is relative to standardizing that a little bit more. And so what we are asking, just first and foremost, is to get to that national average of $90 per person funding when we take into consideration both state and local resources. Our recommendations are to provide local health departments with stable, recurring, and flexible funding in addition to the state level, and help build and sustain those foundational public health capacities that this group defines. We want to provide local health departments with administrative supports and other flexibilities to leverage all of those available funding sources, taking into account the fact that the state health department has a lot of economy of scale and purchasing power that we can bring to bear that locals may not be able to. And finally, increasing the capacity at both the state and local levels to direct resources to areas of need, establishing the value of the public health system, and calculating that return on investment so that we can empirically show why public health is important and sustain that investment going forward. Draft recommendation 1, as I said, focuses on local health departments as well as state funding in order to expand and sustain those foundational public health capacities. Possible action items include increasing the the local health maintenance fund appropriation in order to increase the allocations that go to the local health departments. In conversations with our local partners, this is a very well utilized and trusted funding resource. It is flexible for them. Their appropriating authorities, so the city or county councils understand it, and it's usually not as challenging for it to go through. So we felt that that was an appropriate path to use going forward. We also wanted to reflect this idea that what is occurring today should continue in terms of a maintenance of effort. And so what we do not want is this significant infusion of funding to supplant local resources, and we find ourselves in a net zero investment situation. So we do want to ask that what is being taxed what is being used from tax levies today continues to be used going forward. And at the same time, local health departments have a fund into which those are deposited. Draft recommendation 2 focuses on providing supports and other flexibilities to local health departments and really looking at different funding streams. So in particular, billing for those clinical services and other services that can be billed to Medicare and Medicaid. So we want to ensure that we address that through a centralized process, much as we have done today with the vaccine billing solution. So we are in the process of looking of how to sustain that going forward based on the successes of what we've done with COVID billing. I want to stress, as Dr. Box alluded to earlier, this is for counties who want to participate. So those counties who have successful billing operations today, we're not looking to supplant that or create a you must participate option. In terms of creating a surge staffing program to increase capacity at the local health department levels, one of the things we talked about was the success of the model that we used with the CDC Foundation with embedded staffing and the ability to leverage staff augmentation in lieu of direct grant dollars. And so for counties who say, we have struggles getting these resources put in, it would just be easier if you gave us a resource. We wanted to look at creating a program relative to that, again, where counties would be interested in participating. I will say from our side at the state health department, we have found that to be a very rewarding relationship and have used it pretty successfully. And then the third option here is a little bit esoteric, but bear with me. For local health departments that have merged, allowing them to operate as a municipal corporation under an appointed board by the counties that are involved in that process. Today, we only have one health department that functions this way. That is the Marion County Health Department. It does allow them a little more administrative flexibility. They are still subject to oversight by the respective authorities. However, they operate a little bit more like a corporation in the sense that they're presenting their budget once or taking proposals to the appointing authority, as needed, as opposed to every single appropriation having to be done. So that was another option for consideration there. The third and final recommendation pertains to the transparency piece that I discussed earlier. The data in this area has not always been easy to obtain, as I mentioned, and so this is really about helping us standardize how we calculate that return on investment and how our local health partners are tracking their information relative to budget and expenditures. We've found that on the budget side of things, it is much easier to pull information from the Department of Local Government Finance, but that really represents kind of the high watermark relative to taxes. It doesn't necessarily reflect revenues relative to permits and licenses or other sources, or even federal grants and state grants. What we really need to do is look at the expenditure side of things. And so when we look at money going out, it's kind of more difficult for us to really make sense of that. And so we've been really relying heavily for quite some time on local health departments to report that information to us. But as we know, there are multiple ways of doing that. And so even in conversations with the State Board of Accounts, this is not necessarily something that can be easily extracted today. So this goal really speaks to us reaching out to State Board of Accounts, Department of Local Government Finance, and working with our local health partners to create a more consistent way of tracking and reporting those data so that we can report back to the legislature and others meaningful progress on how we're using this investment that we would potentially be receiving, and comparing that relative to outcomes in terms of the program performance. And then similarly, we really want to make sure that what we've heard consistently time and again, I think from really the beginning to even more recently, is folks just don't understand what public health does. And what we want to do is ensure that as part of the conversation we're having with individuals in educating them on what we do, it's making the case for why certain financial aspects need to occur, helping also train our local health partners on the financial aspects that they demonstrated, or excuse me, that they shared through the survey that they feel they lack in terms of skill set. So it's working with the local elected officials to help them understand, why certain grants function a certain way, why certain financial processes occur a certain way, and working with local health partners to ensure that they understand the relationship between their budgeting process, the need for certain things to go through appropriation cycles, as well as forming a really good relationship with their county auditor, which is actually someone we've not really talked a lot about in this group, but is really critical in terms of ensuring that books are managed appropriately and that local health partners understand what their resources are. So with that, I will turn it over to you folks.
Well, thank you very much. That was great. Okay, open to the floor. Kim?
Sure, just a very general comment that I was reminded of during emergency preparedness, and that is just that critical importance of the increased, stable, recurring, flexible, because what we heard from the conversations I referenced over and over from local health department folks or folks who have worked there is just that the grant funding opportunities are just not even feasible often from a capacity for applying, for managing, and having to, just to use the example, they're not the right recommendations, but we're at such a sort of low starting point in terms of getting to standard operating, that those special funding that is specialized is just still not always helpful because we don't have the baseline. So I just wanted to make sure that we're all remembering that piece, that we cannot solve this with dedicated grant funding. And
yeah, no, that's a really valid point. And time and again, and it's a problem across the country. State after state have problems with where federal funding or other grants come in, they just can't either accept it, they can't move it, they don't have the mechanisms. And the smarter, the pre-positioning or the pre-development of whatever those mechanisms are is really helps everybody. And really
predicated on that stable, flexible.
Exactly. Okay, I don't know which one went first. So,
Go ahead.
well, Paul, I'm going to give you the first one because
All right.
Dr. Welsh, we know has a well thought out.
That might not be so well thought out.
Not implying that.
So one of the issues is related to the comment that you made, Shane, around the need for uniform data. And I noticed your comment about adopting uniform chart of accounts for public health. And I would just note that this is a long-standing issue. It's one that education addressed probably 3 decades ago or more, and public health has never really embraced the uniform chart of accounts, and it's crucial if we're going to make progress. So I really appreciate you mentioning that, and given the fact that there are substantial limitations on Indiana's financial data, I just want to remind folks that one of the things that we found in our review of the public health system in Indiana is a really interesting fact, which is that around 70% of funding for local public health departments come from local sources. And that's exactly opposite from most states, where about 70% of local funding comes from state and federal sources. So I would hope that as we think about ways of which to increase our funding, we need to recognize this is not just about putting a greater burden on the local communities, because for the most part, it's not there. And again, I would defer to our county commissioners and mayors to support that, but that's my understanding. The other issue is related to this notion around foundational public health capacities. And I think it's true that we as a commission have endorsed this notion around foundational public health capacities, and that regardless of where you live in the state, there are certain public health services that need to be available. And I think by extension, we could say that every county would require a certain level of local service. And I think it would go a long ways to helping ease the mind of local officials if we could be really clear about what is absolutely required to be in each local jurisdiction. For example, vital records, being able to obtain a death or a birth certificate, being able to deal with issues around environmental health, restaurant inspections, and septic tank permits, those kinds of things. That may not be what we ultimately choose, but it just seems to me that ultimately we need to agree on what those core positions are in each of the counties. And then we need to go to the next level, which is what I think we've also agreed, which is related to our regional approach and that sharing. And so again, the idea would be, it seems to me that once, and I heard Dr. Bach say that it may be that we need to redefine those those districts or regions, which is fine, but at some point in time, we need to think about the budgeting at a regional level. And then being able to just allocate funding so that you have some idea of what these regional capacities are, what it's going to cost, how it's going to be shared. And I know it wasn't in here because that in and of itself is just a huge job, but I don't know how you actually develop the budgets until you actually get to that level of specificity. And then the last thing is the state level. And again, I just want to say, and perhaps it's hard for Dr. Box and others to say it, but I think we have one of the lowest resource state health departments in the country. We absolutely need to invest in our state health department in terms of expertise and functionality. And so that's got to be in this report as well. And I guess at some point we'll get to this level of specificity, and maybe it'll get to 90, but maybe it'll be more than 90 per capita. And I know we can't do it immediately, but it just seems to me that this is the crux of this report. And so Dr. Box, I know you're thinking about this, and I'm just anxious to know what your plan is in terms of spelling this out.
So in our infrastructure and services, we did talk about what would be still required at the local level. I think I've heard very clearly from the local county commissioners and other people, they want to maintain the permitting and the licensure. So as you say, the septic systems, and they want to do the food safety. To my mind, every county must have the ability to give immunizations, and every county must have birth and death registry. Emergency preparedness, our recommendation has been at least a half of an FTE for that. But then everything else I think can come up, to a higher level if Marion County, Allen County, St. Joe County wants to maintain their own data analytics, they can do that, and they can continue to do that. But if we bring data analysis, and if we bring legal, I don't need a lawyer for every district, but at least 3 lawyers maybe that would be dedicated.
But you
to
could agree on
doing-
functionality at a regional level.
Right, and the epidemiology at that level. So yeah, we have really broken that down. We actually are working with our chief financial officer to break down what the cost of that would be at the regional or district, I would say, level as we do that. But I agree with you. I worry a little bit when we talk about getting up to just what the national average is. Most of those people that were at the average would tell you they weren't capable of responding to the pandemic the way they wanted to. That they had big gaps in their ability to respond to. So that's why Shane points out things like, this doesn't really cover what we need for trauma. And it doesn't cover EMS. It doesn't cover making sure every school has access to a nurse, a school nurse. So the money can be somewhat higher than what you think.
Well, I also think that it's really important, and I've heard very clearly from folks in this room that it would be really important to come up with some uniformity around minimum qualifications and salary ranges and so forth. Because it is very, very difficult to recruit in many of our counties, and there's really not an awareness of the market level for these jobs. So going to the next one, and I've just got 2 more and I'll be done. But related to draft recommendation 1, Shane, and you mentioned it, the supplanting. I'm sorry to say that, and since I've been here now, I've been here 9 years. Every time I meet with our local health departments, they talk about this somewhat draconian approach towards supplanting local budgets, where there's this negative incentive. So commissioners set a budget, and I'm not blaming them. I just think it's got to be fixed, which is they say if you get additional clinical revenue, or if you get grant revenue, then we'll just reduce our local support for your department, which creates a negative incentive for creativity and being, entrepreneurial. It essentially says don't bother, and that's the way that our health officers are operating in many cases, and it's kind of hard to blame them. So it seems to me, in addition to maintenance of effort, we also need to get some agreement with our colleagues at the county and city level. And again, I certainly respect that it's ultimately going to have to be their decision, but we've got to fix that. And it's really kind of shameful that that's still in place, and we could just do better.
Yeah.
So I want to make sure that we talk about that.
Thanks for that. And that is a tough topic because I think at the state health department, we certainly agree with that. However, as we've talked with local elected officials and others, there's a more nuanced vision of that relative to, as you mentioned, constraints within, what their tax base is and so forth. And so, they're trying to look at the more macro picture for the entire county. In particular, though, when we have seen certain services be carved out as exempt from these appropriations or supplementation requirements, they then become kind of the black sheep of the county government and singled out for retaliatory treatment. So we want to make sure that public health does not find itself similarly in that way. And I think that's where, by braiding in this conversation about return on investment and having empirical data to show the good work that we're doing in the communities, it will help maybe make the case for additional investments going forward.
And I think if we are talking about substantial increase in state funding for the local level, perhaps it takes some of that pressure off, because I understand at the end of the day, they better make ends meet, but it just seems to be a perverse incentive for our health department. So
we did certainly feel, though, that there has to be, at least a floor.
Right.
This is all kind of predicated in new money coming into the system.
The last thing I would mention under this notion around accountability is that I do think it makes sense for us to be able to have some sort of third-party verification of capacity. And again, I would suggest that accreditation offers opportunities for measurement of capacity and the at least minimum requirements. And so I would add that as a consideration. Although I know we've talked about the pros and cons of it, but thank you.
Thank you. David?
First, a quick question, and I was trying to remember the number you previously spoke about what our average is in Indiana for county.
Yeah, so at the state level, when you look at the investment through at the state level, it's $55 per person. When you look at the November information and we were looking at it by county and the tax levies, that was more in line with like, $30 to $40 per person. So if you're thinking about, why are there some different numbers flowing out there, that's why, because those are two different things being measured.
I just wanted to get it on, since this is a public meeting, to get it out there again so that we can see that we're working from quite a deficit from the national average. Really like your recommendations as a county health officer. Really appreciate any help with the local health maintenance fund. That has been a godsend over the years, and expanding that to regional certainly would help. And I think as we educate the public and the elected officials, we need to talk, like you said, about return on investment, and that we need to take where we're at now as a basement, and we need to get things built up to that upper floors. On the second area, didn't know if there was a way of if groups were interested in combining maybe like an example of best practices where the people had combined, so they kind of know some of the steps that would be required to try to be successful.
Are you talking about like a consolidation between two
Right,
counties?
on your point C in recommendation 2, just if there were examples that people give, like best practices where they have successfully combined.
Yeah.
Maybe worst case scenarios where they tried it and it didn't work.
Yeah.
Just the thought.
We did contemplate that in the governance conversation, and Pam had actually, I think what you'll find in the draft report is actually some recommendations around building some templates and things to assist with that, recognizing that at the moment it's pretty nebulous.
And then on your third recommendation on the last part, I really like the fact that wanted to reach out with training. And Perhaps that could be expanded to involve local health board members and even some staff so that they can have that better, more effective conversation with their local elected officials. And then if they kind of know some of the content, they can encourage them like, well, there's this new program, so that you can understand the nuances a little bit more about public health. And then so that when folks from their local health departments go before their commissioners or go before their county council, they have a little bit better understanding of the nuances so that they can advocate their point more effectively.
Other questions, comments?
I'd like to make one.
Mayor?
Thank you for this. This is really good information. I'm always an advocate for creating the proper incentives for funding. And Dr. Halverson was made the point too that I was zoning in on, which was about accreditation and making sure that minimum level of services are being performed regardless of the size of the health of the county, for example. The amount of deficit that you're describing is already pretty substantial. It sounds like it's over $200 million annually in order just to get to an average. And who wants to be average? We be the best because we know what the future need is and how important it is to our workforce and quality of life and growing our population. So who do we emulate? And I always find that that's a good starting point, which is who do we emulate that actually brings these standards and the funding and the minimum requirements and, you know, something maybe short of an accreditation, because I know accreditation can be difficult and time consuming and expensive in its own way. But have we thought about who should we be emulating to be the model as we go out and talk to various different sizes? And then the second part of that question is, when we rank counties relative to their health outcomes and investment in public health, what do we do with that information? Do we just publish it, or do we communicate back out to the county health departments and say, you're falling short and we need you to raise the bar? Where does that information go to actually create some aspirational goals for either the mayors or the commissioners or the health officers for the counties?
Yeah, great questions. So I'll take the emulation question first. And, nationally, as kind of the way things flow, Minnesota and similar states like that have historically had large investments in public health, and that tends to be reflected in their health outcomes. For the purposes of modernization and I would say innovation, this change from an older style of public health system, we've been looking more at Washington State, Kentucky, and Ohio, particularly the last two, given the geographic proximity. Obviously, we want to kind of be reflective of the cultural norms and kind of what really would work in an Indiana context. And so I think there really is a lot to be gleaned from Kentucky and Ohio. And even Tennessee has some interesting governance and foundational public health services models. So those are the states that we've throughout these presentations kind of referred back to and would probably continue to discuss through the final report and recommendations that we generate. I will highlight in particular, Kentucky and Washington both tied increased investments to foundational public health services and that ability to really deliver at a higher level than what we've seen previously. And so I think there's something to be gleaned there in terms of your incentive piece. And then Ohio, to Dr. Halverson's point and your point about accreditation, did require local health departments to become accredited within I think a 5-year period. And that did change the landscape of local health departments a little bit. I believe they had a number of municipals and so forth. So that created some consolidation. On the county rankings piece, I may ask Dr. Box to weigh in on this, but in my estimation of things, we've not really had the resources at the state level to go back and provide a lot of that analysis to local health departments to help them understand what that means. And so I think this is where we're really looking at not only that local health investment, but state health investment, to Dr. Halverson's point, to help us be able to partner with local health departments to do a community health assessment, to do a community health improvement plan that really are those best practices that inform what should you be doing in your community level, and how do you apply the funding that you're getting in a meaningful way that's aligned to what your community needs are. Dr. Box, do you want to clarify any of that?
So I think it's a really good question, and we don't really sit down and rank the local health departments. Unless Mindy, you're aware of something that I'm not. So those rankings come out from other people. We work really, really hard to try to help counties apply for and get grants, because we're 68% grant funded at the state level. And the money that we usually have to give local health departments, besides that small basic local health maintenance fund, comes through grants that we can help them get. And still, it's quite a challenge, as Mindy has delineated many of the reasons why that's a challenge for our local health departments to do that. But our focus has been more on helping local health departments to be able to apply for and get these grants, and see what we can do as far as partnering with them. But we, as Shane says, I mean, I don't know, Dr. Kane always laughs because she's got what, 850 employees at the. It is more than the State Department. Well, but I mean, I think that is it just says, I mean, we're funded about 48th in the nation. We come in at about 41st in the nation. So I think we work with the money that we have to accomplish what we can, but it's really difficult.
It'd be a value add service.
Definitely be value. I mean, I'm also a big believer in every community having skin in the game. And so they're working hard toward achieving goals that are tied to a reward that might be financially, particularly being able to produce results rather than just throwing money at the problem.
And therein lies the whole need for data analysis and
100%.
Informatics at least the district level, so that we can help. Mindy can probably give you a lot of her data, right? As can Dr. Kane, as can South Bend, but for the most part, most of our counties don't have that data. They don't have a way to look at it, and even when we give them their data back, we oftentimes hear they just don't understand the picture that data is painting for them.
Very good point. Thank you.
Kim?
Well, I was just gonna say, and what do we want that data to tell us, right? To your point, like, how are we using that to achieve the goals, to ensure that we're covering services and growing,
Yeah. I mean, to me, as I hear all of this, again, I'll go back to that district model, health officer that is public health trained. They've got the physician credential. They understand public health. They would then be an incredible resource to take the county health rankings for their 10 counties or whatever, however many counties in their district. Each of those could take a hard look at that. They're going to be cross-fertilizing their knowledge, working with the state health department, with Fairbanks. I mean, you can just envision this whole new energy in the state for the data analytics, and then working with all the local health officers. I mean, it lifts everything if you think about that model to bring that support. Because who's got time? Yeah, I mean, the state doesn't have time now.
Well, and if I
Dr. Walsh, I
might,
don't know how much time you've got.
you remember, we talked also, I think, during Pam's presentation around the critical importance of a local liaison office, someone that actually can attend to the needs of local health departments and bring the resources of the state health department in a robust way for a whole variety of services. And, again, try as you might, right now, it's just not where it needs to be. And I think that it could be a huge advantage, and these data analytics and a whole host of other things could be part of that local liaison responsibility. So it's just all a matter of staffing it appropriately.
Right. Yes, Brad.
I just say, at the end of a kind of a long day, long meeting, we've covered a lot of ground.
Right.
I hope it's not lost on me, and I hope it's not lost on any of us, that the magnitude of the commitment, what that goal is. I mean, yes, it may be to get us to the average, but I don't think that's how we should think about it. Yes, we could be aspirational beyond that, but this is a decades-long issue. So when we look at the opportunity that we have before us to move up in that many rankings, that's how we should think about it. And it's just sort of a generational opportunity, and just wanted say that. I hope it doesn't get lost at the end of the meeting, so.
I agree. And it's monumental. It really is monumental when you start thinking of it that way. And then you think about, I mean, I got pretty excited about the workforce that, there's an opportunity here to innovate in the state of Indiana. What with this commission, other states don't have these commissions right now. And just thinking about what the need is and then designing to meet the need and thinking of it at workforce levels.
And if we could
Really
create
exciting.
that visibility around some of our health metrics in the same way that there was so much focus during COVID on the dashboard, and
Exactly.
being able to look at that regionally is just going to increase the conversation. It's going to create maybe competition between regions as they think about being attractive for
Yeah.
employers and other things. There's a lot to be excited about.
Yeah, that's super exciting. Kara and then David?
Yeah, and to piggyback off of what Brian said, is this really our metric of success to determine our success as a commission? To move, to improve these rankings that we're kind of talking about funding? I have this conversation with Shane earlier this week. Have we defined what when this is all said and done, what is success looking like with all these recommendations and the goals? How do we know we've achieved what the purpose of this commission?
I think the most important thing is that success is the ability to look at all aspects of all areas in the state of Indiana and know that whether you live in Wayne County or you live in Miami County or you live in Marion County or you live in Allen County, that you have access to the same foundational public health services. And that, we probably have to start here and grow those services. But it's really important to me that that's what happens through this commission.
So, and this might be a good time to talk about the 5 reasons,
5
right?
reasons.
Right. I mean, we were talking, and actually Dr. Box and Senator Kinley have already done their homework, writing up 5 reasons why the commission. What are the 5 top reasons? So it'd be fascinating to hear, each. Sorry, you don't get to see those ahead of time. You get to pick your top 5, but those 5 reasons, and then roll those up into kind of the compelling 5 reasons we're doing this. And then what's that metric of success, right? Here's why you're doing it. Now, how do you measure the success would follow easily, I think, from that.
And I think our point was to make that a part of, the executive summary. What is this commission? What are the measures of success? What are those things why do we need to have this commission? And we've certainly talked about it.
Dennis?
And my comment would be, that's what, if the end result is to go to the legislature and ask for more money, then they're going to want to see something like that. If we fund more, if we put more money into public health, what is, and you use it in here, what's the return on investment, or what's the outcome going to be for the state of Indiana? And are we going to be able to show then by funding and so on, that this is going to result in Indiana moving up food chain, if you want to call it, so on, so that we're at a higher level of health than we were. Otherwise, why fund it? And how will this money be used for X? All the things we've been talking about.
Exactly.
If I was a state legislator, and Dr. Welsh needs to be there, but if I was a state legislator, that's what I would be thinking about. Yeah.
So first, Dr. Halverson, I think we got one of the first things on the topics to educate the health officers and staff is, what do you do with your county status and metrics, and how do you address that? So I think we're already working on the education.
There you go.
I think we actually already having some measure of success just from everyone's participation in the information that's a lot of information's gone over, some concrete ideas. This group needs to know that we're being watched. We're not only by the state, but by colleagues across the nation, because they want to see what we do, see what we come up with. The report that I mentioned earlier is coming out, that I know we're on target with a lot of the things that we're talking about, because others that have looked at this are in the same department, looking at data, looking at workforce issues, looking at cross-jurisdictional collaboration. funding sources, networks for folks, particularly in rural. So people are taking note of what's being done here. And we've taken the first hard step of getting together, asking the hard questions, and listening to folks across the state. We have, how successful we'll be will depend on the legislature and the governor, and how people take the recommendations moving forward, whether it's at the county, regional, or state level. But I can tell you, others are watching and they're interested in what we come up with, because they recognize they have gaps in their public health delivery also, and they'd like to learn from our experience.
Very good. And with that, we actually are time to conclude the meeting. How about that? So thank you, Shane. That was great. Really terrific work. Thanks to all of our presenters today and the recommendations. So our next meeting is Thursday, June 30th from 1 to 3 p.m. So that one's going to be a 2-hour is what I have here. That topic will be to review the draft report, resolve pending items. I mean, clearly we had a lot of discussion today about the work we did in April. So then the next meeting, again, we'll address open items, review the draft like we did today. Then we are expecting, as Dr. Bach said, a meeting in July 21. And that'll be to finalize the work and adopt the report. Again, we're looking at a 2-hour meeting, 1 to 3. There will be, now we understand people may be on vacation, right? Or there may be other things. So if you need a remote option, talk to Shane, right? Or Tammy, I believe, and we'll accommodate. Because we don't want to lose people. We want, obviously, it's a committed and involved group. So we don't want to lose folks and understanding that it's summertime. And with that, I'm told to gavel in at 4:03.
You follow instructions well.
Well, I might get a little messy in the middle. That was our.
Did you get the contract? Good. Okay, yes.
Fun stuff. It was always a pleasure. Good seeing you guys. Take care. Thank you. Nice to see you.
I know. Well, good to see you. Sorry. The same metrics that matter to management came to mind. Yeah. No, I think maybe, yeah.